Having a hypersensitivity means that someone's immune system has reacted to something in such a way that it ends up damaging them, as opposed to protecting them. There are 4 different types of hypersensitivities, and in the first type, or type 1, the reactions rely on immunoglobulin E, or IgE antibody, which is a specific type of antibody. The other major ones being IgG, IgA, IgM, and IgD. So because IgE is involved with type 1 hypersensitivity reactions, they're also called IgE-mediated hypersensitivities. This type of reaction is also sometimes called immediate hypersensitivity, because the reactions happen super fast, on the order of minutes. So most allergic reactions are IgE-mediated, and therefore most allergies are type 1 hypersensitivity reactions. Allergy comes from the Greek allos, which roughly means other, and ergon, which means reactivity. Essentially, allergies are reactions to molecules from outside your own body that most people don't react to. And these are specific molecules from things you might breathe or take in, like foods, animal dander, bee stings, mold, drugs or medications, and pollen. But you can also mount an allergic reaction to things you come in contact with on your skin, like latex, lotions, and soaps. These specific molecules are also called antigens, and when they cause an allergic reaction, they're called allergens. An allergic reaction happens in 2 steps: a first exposure or sensitization, and then a subsequent exposure, which is when it gets a lot more serious. People that react to these allergens usually have a genetic predisposition to having overreactions to unknown molecules or allergens. And this means that these people have certain genes that cause their T helper cells to be more hypersensitive to certain antigens. Since the production of these T helper cells is genetically linked, allergies to things tend to run in families. So let's say this person breathes in some ragweed pollen. That person happens to have T helper cells that can bind to a specific molecule on the pollen, making that molecule an allergen. First off, that allergen gets picked up by immune cells hanging out in the membranes along the airways, which then grab the molecule and migrate to the lymph nodes, which happens regardless of if the person's allergic or not. These cells are antigen-presenting cells, since they carry the antigen to the lymph nodes and present it to the T helper cells living there. Dendritic cells and macrophages are examples of antigen-presenting cells. When the person's allergic, the antigen-presenting cell will also express co-stimulatory molecules, which are needed to mount an effective immune response. Before the T helper cell sees the antigen, though, it's called a naive T helper cell, since even though it's built to recognize the antigen, it hasn't actually seen it before. When that T helper cell gets its hands on the antigen, though, and also binds the co-stimulatory molecule, it's now been primed, and the naive T helper cell changes into a different sort of T helper cell. Usually in type 1 hypersensitivity, it differentiates into a type 2 T helper cell, or just Th2 cell. And this step happens in response to various small proteins or interleukins that might be floating around at the time. Some interleukins that sway the T helper cell into turning into a Th2 cell are interleukin 4, interleukin 5, and interleukin 10. And these are all cytokines, and they're given numbers because it's easier to keep track of them that way. At any rate, the excited Th2 cells release a bit of their own interleukin 4 and get the B cells to undergo antibody class switching. And so the B cell switches from making IgM antibodies to making IgE antibodies, which are specific to that ragweed pollen in our example. Th2 cells also release some interleukin 5, which stimulates production and activation of eosinophils, a granulocyte, which is a type of white blood cell that degranulates, or essentially releases a whole bunch of toxic substances that can damage both invading cells and nearby host cells. These ragweed-specific IgE antibodies have a high affinity for, or basically really like, Fc epsilon receptors on mast cells, another type of granulocyte. So they quickly attach themselves to the surface of the mast cells. These antibodies are also called cytotropic antibodies, since they can bind to cell surfaces. At this point, it's like the mast cell's been geared up for combat, and is ready for action, and therefore we're finished with the sensitization phase. Now let's say that same person breathes in some ragweed pollen again. Maybe a few months later, a second exposure. Well, the souped up mast cells, using their coat of antibodies, binds to the antigen. Actually, it takes 2 or more bound antigens to cross-link the IgE antibodies, which signals the mast cell to degranulate and release a bunch of pro-inflammatory molecules called mediators that ultimately causes the effects seen in an allergic reaction. One of the major mediators released in an allergic reaction is histamine. Histamine binds to H1 receptors and causes the smooth muscles around the bronchi to contract, which means the airways get smaller, making it more difficult to breathe. It also causes blood vessel dilation and increased permeability of the blood vessel walls, meaning that while blood vessel diameter increases and blood flow to the affected area increases, fluid is allowed to more easily leak out the blood vessel walls and get into the interstitium, the spaces between the cells, which causes edema and swelling and urticaria, or hives. In addition to histamine, mast cells release other pro-inflammatory mediators, including some that activate eosinophils and proteases, which chop up large proteins into small peptides. The effects of these molecules are called early phase reactions, and they happen within minutes of the second exposure. There are also late phase reactions, though, which happen 8 to 12 hours after the second exposure, where even more immune cells like Th2 cells, eosinophils, and basophils, yet another type of granulocyte, are recruited to the site where the allergen is located because of the cytokines and pro-inflammatory molecules produced during that early phase. These include some of those same interleukins again, interleukin 4, interleukin 5, and interleukin 10, but also leukotrienes, which are smaller molecules made out of fatty acids and facilitate communication between a local group of cells. Two leukotrienes in particular, LTB4 and LTC4, can not only cause smooth muscle contraction and damage to the epithelium, like histamine, but they can attract immune cells, like neutrophils, mast cells, and eosinophils, to their location even after the allergen is long gone. A lot of people with allergic reactions experience mild symptoms, like hives, eczema, allergic rhinitis, which is inflammation of the nose, as well as asthma. Certain people, though, when exposed to a large load of specific allergens, like with bee stings, seafood, or peanuts, can have a really severe and potentially life-threatening allergic reaction. The increased vascular permeability, along with the constriction of airways, can be severe enough such that the body can't supply the vital organs, like the brain, with enough oxygen-rich blood, a condition known as anaphylactic shock. Treatment for type 1 hypersensitivity can involve a variety of medications. Antihistamines act to block the effects of histamine, which reduces vascular permeability and bronchoconstriction. Also, there are corticosteroids, which can be used to reduce the inflammatory response, as well as epinephrine, which is sometimes given during severe reactions via intramuscular injections through an EpiPen or intravenous injection. Epinephrine can help constrict blood vessels and prevent anaphylactic shock. If there's ever a serious type 1 hypersensitivity reaction that requires something like steroids or epinephrine, it's super important to get medical attention, because type 1 hypersensitivity reactions can be really serious and can sometimes get slightly better before getting worse again. Thanks for watching. You can help support us by donating on Patreon, or subscribing to our channel, or telling your friends about us on social media.
Anaphylaxis refers to an acute, potentially life-threatening allergic reaction that occurs in response to antigens that don't cause problems for most people. Common anaphylactic triggers include foods like nuts, milk, shellfish, and eggs, as well as certain medications like penicillin, IV contrast agents, and insect stings. The first exposure to a specific antigen is called sensitization and typically occurs with minimal or no signs or symptoms. But on second exposure, IgE-mediated activation of basophils and mast cells lead to the release of pro-inflammatory mediators such as histamine, prostaglandins, and cytokines. These mediators reach the bloodstream and spread throughout the body, causing an overwhelming systemic inflammatory reaction that can ultimately result in anaphylactic shock or even death. Now, if you suspect anaphylaxis, you should first perform an ABCDE assessment to determine if your patient is unstable or stable. If the patient is unstable, stabilize the airway, breathing, and circulation. This means that you might need to intubate the patient. Do this as soon as possible, since airway edema can progress quite quickly and become more severe, making intubation very difficult. However, if you are unable to intubate, immediately call the surgery team to evaluate for possible surgical airway management, such as cricothyrotomy. Next, obtain IV access, and if your patient is hypotensive, start IV fluids for volume resuscitation. In severe cases, you may need to administer immediate intramuscular epinephrine even before obtaining very focused history and physical examination. Finally, put your patient on continuous vital sign monitoring such as pulse oximetry, blood pressure, and heart rate. Let's go back to the ABCDE assessment. Now, if the patient is instead stable, obtain IV access and put them on continuous vital sign monitoring. Now that you've initiated the acute management in both stable and unstable individuals, it's important to quickly obtain focused history and physical examination. Also, order labs, primarily tryptase, which is a good indicator of mast cell degranulation. History often reveals definite or at least suspected recent allergen exposure, but in some cases, the trigger can remain unknown. Next, physical examination typically reveals mucocutaneous, respiratory, cardiovascular, and gastrointestinal findings. Common mucocutaneous findings include urticaria, intense itching, and edema of the mucous membranes. In severe cases, edema of the larynx can result in laryngeal edema, which can be associated with voice hoarseness and stridor. On the other hand, common respiratory findings include labored breathing and wheezing, while cardiovascular manifestations include hypotension and syncope. In addition, if the gastrointestinal system is affected, the patient might present with crampy abdominal pain and vomiting. Finally, labs might reveal an elevated tryptase level, which helps confirm the diagnosis. However, keep in mind that tryptase won't peak until 1 to 1.5 hours after the onset of symptoms. Now that you have identified anaphylaxis, there are a few measures you'll want to take immediately. First, administer intramuscular epinephrine into the lateral thigh at the midpoint. This should not be delayed for any reason. Epinephrine is generally well tolerated and there are no absolute contraindications to its administration. Epinephrine raises blood pressure, reduces bronchospasm, and counteracts the effect of circulating inflammatory mediators. In children weighing less than 25 kilograms, administer 0.15 milligrams of epinephrine, while in children weighing more than 25 kilograms and adults, administer 0.30 milligrams. Next, put your patient in an appropriate position based on their clinical presentation. If your patient presents with cardiovascular manifestations such as hypotension, lay them in a supine position with the legs elevated to maximize central perfusion. Alternatively, if they are vomiting or unconscious, position them in a recovery position. Moreover, pregnant patients should always be positioned on the left side to avoid compression of the inferior vena cava, which can lead to further cardiovascular complications. If they present with respiratory manifestations, put them in a sitting position with their legs outstretched to maximize lung expansion. Finally, if the patient is a baby or child, hold them flat, not upright. Once your patient is appropriately positioned, look for the trigger. If you identify the potential trigger, remove it. For example, you can stop the infusion of a causative medication or remove an insect stinger stuck in the skin. However, keep in mind that this is often not possible because triggers like nuts or shellfish might have been ingested. Next, provide supplemental oxygen and determine whether or not your patient requires additional secondary supportive measures. If your patient is hypotensive, administer IV fluids. If they have a marked stridor, use nebulized epinephrine to relieve upper airway obstruction. And finally, if there's wheezing, you can go with nebulized beta 2 agonists to relieve bronchospasm. Finally, consider H1 antagonists to alleviate symptoms of urticaria and itching. All right, you're done with the initial management. Now you need to assess their response to epinephrine. The primary measures you need to assess include hemodynamic stability and respiratory status. Ideally, your patient's systolic blood pressure is now above 90 millimeters of mercury, oxygen saturation is above 90%, and signs and symptoms of respiratory distress have improved. These findings indicate adequate response to treatment so far. But what if the patient shows inadequate response? If their systolic blood pressure remains below 90 millimeters of mercury, oxygen saturation is below 90%, or there's no respiratory improvement, repeat intramuscular epinephrine every 5 to 15 minutes. Most patients improve after 1 or 2 doses. If inadequate response persists after 3 intramuscular doses, the patient may require IV administration of epinephrine. Additionally, if needed, provide secondary support measures. Continue treatment until signs and symptoms of anaphylaxis resolve and your patient achieves hemodynamic and respiratory stability. Now, let's look at the next steps once we achieve adequate response to treatment. Keep in mind that even after successful treatment of anaphylaxis and full resolution of all signs and symptoms, your patient may experience a biphasic reaction. Biphasic reaction refers to recurrent anaphylactic symptoms, which typically occur within 72 hours after the initial episode has resolved. The incidence is highest in the first 6 hours, so monitor your patient closely during this time period. If your patient remains stable during this period, meaning there's no biphasic reaction, prescribe them self-injectable epinephrine, educate them on allergen avoidance, and refer them to an allergy specialist for further follow-up and antigen sensitivity testing. On the other hand, let's say your patient did develop a biphasic reaction. If they develop recurrent symptoms of anaphylaxis, re-administer intramuscular epinephrine immediately. Additionally, if needed, provide secondary supportive measures. Once stable, keep monitoring them for another biphasic reaction. If no reaction occurs, prescribe them self-injectable epinephrine, educate them on allergen avoidance, and refer them to an allergy specialist for further follow-up. All right, as a quick recap, anaphylaxis is a life-threatening condition that needs to be diagnosed quickly. Unstable patients usually require intubation, IV access, IV fluids, and vital sign monitoring, while stable individuals require IV access and vital sign monitoring only. Once you suspect anaphylaxis, obtain focused history and physical examination and order labs, primarily tryptase. A focused history and physical examination usually reveals the mucocutaneous, respiratory, cardiovascular, and gastrointestinal manifestations, while labs might reveal elevated tryptase. Once you identify anaphylaxis, administer epinephrine intramuscularly, put your patient in an appropriate position, and remove potential triggers. Additionally, provide supplemental oxygen and secondary supportive measures such as IV fluids, nebulized epinephrine, nebulized beta 2 agonists, and H1 antagonists. Once you've completed these initial management, assess the patient's response to epinephrine. If there's no improvement, repeat intramuscular epinephrine every 5 to 15 minutes and continue secondary supportive measures until improvement. On the other hand, if the symptoms of anaphylaxis fully resolve, continue to monitor your patient for a biphasic reaction for at least 6 hours. If a biphasic reaction occurs, re-administer epinephrine intramuscularly and provide secondary supportive measures if needed. Alternatively, if there's no biphasic reaction or the biphasic reaction has resolved, prescribe self-injectable epinephrine, educate patients on allergen avoidance, and refer them to an allergy specialist for further follow-ups.
Anaphylaxis comes from the Greek word ana, which roughly means against, and phylaxis, which means protection, implying that someone's immune system has reacted to something in such a way that ends up damaging them, instead of protecting them. It's basically a severe type of allergic reaction that affects multiple organ systems and is potentially life-threatening. Normally, the immune system recognizes and acts against pathogens that can cause disease. These pathogens have specific molecules on their surface, called antigens, and they help trigger an immune response. In some individuals, though, the immune system overreacts and starts targeting harmless molecules that don't cause any problems for most people. These include molecules found in foods like peanuts and shellfish, as well as medications like antibiotics, and in the venom of insect bites. In most cases, there might be a mild to moderate allergy, but sometimes things get really serious, involving 2 or more organ systems, and at that point it's called anaphylaxis. Anaphylaxis, just like any allergic response, happens in 2 steps: a first exposure or sensitization, and then a subsequent exposure, which is when it actually gets a lot worse. So let's say a person is stung by a bee from a nearby beehive for the first time in their life. When the bee pierces the skin with its stinger, its venom gets into the skin. Part of that venom molecule can get picked up by a dendritic cell, which is a type of immune cell. The dendritic cell gobbles up the foreign particle and presents it to a nearby lymphocyte, called a T cell. If the T cell is activated, it starts to produce cytokines, which stimulate B cells, another group of lymphocytes, which produce IgE antibodies. These IgE antibodies get released into the bloodstream and bind to the surface of mast cells and basophils, which are immune cells that are full of granules that contain pro-inflammatory molecules. Okay, now let's say that same person is stung by a bee again, maybe a few months later. It's probably time for this person to move away from this beehive, because they're obviously less than ideal neighbors. Nevertheless, with this second exposure, the mast cells and basophils, which already have IgE antibodies on their surface, bind to the antigen and release their pro-inflammatory molecules. In a simple allergic reaction, these molecules would cause some localized damage, like swelling around the sting site. In anaphylaxis, these molecules leak into the bloodstream and reach multiple organ systems. Now, one of the important molecules is histamine, which causes the smooth muscle that lines the bronchi and gastrointestinal tract to contract, making those passageways narrow and tougher for air and food to get through. At the same time, histamine causes blood vessel dilation and increases permeability, meaning that while blood vessel diameter and blood flow to the affected area increases, fluid is also allowed to more easily leak out of the blood vessel wall and get into the interstitium, which is the space between cells. That causes the pressure in the vessels to fall and causes swelling or edema, as well as urticaria or hives. In addition to histamine, tryptase is also released by mast cells. Tryptase is a type of protease that breaks down proteins, causing tissue injury. In some cases, mast cells and basophils also start synthesizing small proteins, called cytokines, like interleukin 4 and interleukin 13, that signals the B cells to make more IgE antibodies, and tumor necrosis factor alpha. But they also make leukotrienes, which are smaller molecules made out of fatty acids, like leukotriene B4 and leukotriene C4, which can attract immune cells, like neutrophils, mast cells, and eosinophils to their location even after the allergen is long gone. Since all these signaling molecules take a while to be formed, though, their effects don't get seen until hours later. Now, although most anaphylactic reactions involve IgE, sometimes anaphylactic reactions don't. For example, blood products, including intravenous IgG antibodies, used to treat a number of autoimmune and infectious diseases, can sometimes bind to various circulating antigens of the host and form immune complexes. These immune complexes can activate complement proteins, which are called anaphylatoxins, specifically complement 3, complement 4, and complement 5. And these can trigger mast cell and basophil degranulation. Both the IgE and non-IgE mediated mechanisms are considered immunologic causes of anaphylaxis, and they're responsible for the vast majority of anaphylactic reactions. But in rare cases, certain agents like contrast mediums and opioids can cause direct non-immunologic degranulation of mast cells and basophils, meaning without involvement of IgE, other antibodies, or immune complexes. The mechanism of how that happens, though, isn't well understood. Anaphylaxis causes symptoms in multiple body systems. For example, tissues all over the body might start to swell up, called angioedema. And there might also be respiratory symptoms, like shortness of breath, coughing, or wheezing. Anaphylaxis can also cause gastrointestinal symptoms like abdominal cramps, vomiting, or diarrhea. In more extreme cases, there can be widespread vasodilation, causing the blood pressure to dramatically drop. If blood pressure gets so low that the body can't supply vital organs, like the brain, with enough oxygen, it's called anaphylactic shock. Reduced blood supply to the heart muscle can cause myocardial infarction, or heart attack, especially in individuals who already have an underlying heart disease. And reduced blood supply to the brain can cause loss of consciousness. Most commonly, symptoms of anaphylaxis peak within 30 minutes, but sometimes symptoms can go away and then recur hours later without additional exposure to the allergen. These are called biphasic anaphylactic reactions. Even less commonly, anaphylactic reactions can last for days, in which case they're called protracted reactions. Diagnosis of anaphylaxis is usually based on identifying a likely trigger and seeing that multiple body systems are affected. Specific lab tests can help, like histamine, tryptase, and IgE levels, all of which are usually elevated. Treatment for anaphylaxis starts with epinephrine, most often given intramuscularly. First off, epinephrine causes blood vessel constriction, which decreases swelling and increases blood pressure. Second, epinephrine boosts the heart's contractility and heart rate, which can help prevent cardiovascular collapse. And third, it relaxes smooth muscles that line the bronchi, helping the airways to open up. Antihistamines can also be used to reverse the actions of histamine. Anaphylaxis, and especially anaphylactic shock, are medical emergencies, because if there's airway swelling, it can close off the airway. That's why they have to be treated right away. Sometimes that means airway management, supplemental oxygen, and large amounts of intravenous fluids. Close monitoring for at least a day after symptoms resolve is important, in case there's a biphasic reaction in another wave of symptoms. Alright, as a quick recap. Anaphylaxis is an acute, potentially deadly allergic reaction caused by the release of chemical mediators by mast cells and basophils, and affects typically 2 or more organ systems, most often the skin and the respiratory system. Immediate treatment with intramuscular epinephrine and close monitoring of the airway are both extremely important. Asthma is a health problem that can make it hard to breathe. This can be very frustrating and scary. For kids, it can make them miss a lot of school. But if you know what to do, asthma can be controlled. With the help of parents, teachers, nurses, and doctors, the good news is that children with asthma can live healthy, active lives. They can go to school, play sports, play the trumpet, or whatever they love to do. When you breathe, air moves from your nose or mouth into your lungs by passing through small tubes called airways. People with asthma have trouble breathing because these airways get narrower, making it hard for air to move in and out. Let's take a closer look at the airways inside the lungs. One reason that asthma makes it hard to breathe is that it causes a lot of irritation and swelling, making the walls of the airways get thick. The muscles around the airways also get irritated and squeeze, making them even more narrow. With asthma, the irritation also leads to more mucus, which can clog the airways. Breathing with asthma can feel like breathing through a thin straw. It's hard to move air in and out, and can be very tiring. Asthma is different for everyone. The most common symptoms are coughing, chest tightness, getting tired easily, and wheezing. Wheezing is a high-pitched whistling sound that comes from the air trying to get in and out of the lungs through narrow airways. In some children, cough might be the only symptom, and might increase at night or while napping, making it hard to sleep. Some people with asthma have symptoms almost every day. Others have symptoms once every few months. But asthma is a chronic disease, which means it never really goes away. So people with asthma should always have their medications ready. Sometimes asthma symptoms can suddenly get worse, and this is called an asthma attack. During an asthma attack, it can be so hard to breathe that it's hard to talk. If a child is having an asthma attack, you might be able to see them using muscles in their neck or between their ribs to help breathe. Severe asthma attacks are dangerous, require medicine, and might require going to the hospital. Talk to your doctor so you know what to do. An asthma trigger is something that makes your asthma symptoms start up or get worse. Everyone has different triggers, but a common one is cigarette smoke. Cigarette smoke can be harmful even when not in the air because it can get caught in clothes and furniture and still trigger asthma. Other causes inside the house can be things like dust, pets, cockroaches, mold, strong perfumes, and cleaning products. Triggers outside the house can be things like cold air, pollen, grass, and air pollution. Asthma can also be triggered by getting sick with a cold, flu, or other illness. Knowing your triggers and staying away from them can help you control your asthma. Make sure that nobody in the home smokes, and try to keep your home free of cockroaches and mold. On heavy air pollution days, keep children with asthma indoors when possible. Avoid standing too close to cars or buses when their engines are running. And make sure you always have your medicines with you, as you'll need them if your asthma is triggered. If a trigger is something like a cold, asthma symptoms usually improve once the illness goes away. If your asthma is brought on by exercise or sports, it can be tempting to avoid those things. But exercise is an important part of being healthy for everyone, including people with asthma. With the right medications, a person with asthma can live a very active life. Talk to your doctor to make sure everyone in the family with asthma has the right medicine and action plan to stay healthy. There are two types of medication that can help with asthma: relievers and controllers. Both play an important role in helping to manage asthma, but are used very differently. Relievers, sometimes called rescue inhalers, work within minutes to relax the muscles around the airways, and can stop an asthma attack while it's happening. They can make it easier to breathe right away. That's why it's important for everyone with asthma to always have a reliever medication with them in case they need it. People who have asthma symptoms more than a few times a week need to also have a controller medicine. Controllers reduce mucus and swelling, but have to be used every day to work. They don't help right away, but over time they can make the lungs healthier. This will help people with asthma have fewer symptoms and fewer asthma attacks. But during an asthma attack, only relievers will help right away. There are many different kinds of controllers, so talk to your doctor to make sure you have one if you need one. Both of these medication types are usually taken with an inhaler. For children, inhalers should be used with spacers. The spacer helps get the medication deep into the lungs instead of just in the mouth. If the medicine can't get into the lungs, it won't help. Babies and younger kids might need a nebulizer machine, which turns a liquid medication into a mist that can be breathed in. Inhalers and nebulizers take practice to use, so ask your nurse or doctor to watch you do it at your next visit. The inhaler, spacer, and mask can be bulky to carry around, but all people with asthma need to have their rescue medicines close by at all times, because they can be life-saving during an asthma attack. The main thing is that every person with asthma has their own medicine plan, clearly understands how and when to use each medicine, and feels confident that their medicines work for them. This plan is sometimes called an asthma action plan. It's also very important that people who take care of kids with asthma have their medicines and know how to use them. If you have a child with asthma, make sure their school or daycare has the reliever medicine as well as your consent to use it. Ask the school nurse or principal if you need to sign a medication form. They might need this to be able to give the medication to your child for breathing problems at school. Okay, let's review. Asthma is a health condition that affects many people, especially children. It makes the airways in the lungs narrow and tight, making it hard to breathe. Each person can have different asthma triggers, and a common one is cigarette smoke. Medicines include both relievers and controllers, and can help a person with asthma lead a very active life and not have to miss out on school. So work with your doctor to develop an asthma action plan specific for your child, and don't let asthma hold your child back.
Asthma is an episodic, chronic respiratory disorder characterized by airway obstruction caused by inflammation and hyperresponsiveness of the bronchial smooth muscle. Asthma is reversible, which means the obstruction can virtually disappear with medications like bronchodilators, and inducible, which means the obstruction can occur in response to a variety of stimuli, including allergens, irritants, and respiratory tract infections. Clinical manifestations are highly variable, ranging from infrequent and mild symptoms that have minimal functional limitations to frequent acute asthma exacerbations causing significant impairment in functional capacity, and even life-threatening respiratory failure that's often referred to as status asthmaticus. Now, if you suspect asthma, you should first perform an ABCDE assessment to determine whether your patient is stable or unstable. If they're unstable, stabilize their airway, breathing, and circulation, obtain IV access, and begin continuous vital sign monitoring, including heart rate and blood pressure. Next, obtain focused history and physical, order labs, including ABG, and perform spirometry to assess the patient's peak expiratory flow, or PEF for short. Finally, don't forget to place your patient on pulse oximetry. History typically reveals shortness of breath, cough, and chest tightness. On the flip side, physical exam is likely to show tachypnea and use of accessory inspiratory muscles. In addition, auscultation can reveal bilateral wheezing due to inflamed and narrowed airways, and if the condition worsens, you may find decreased or even absent breath sounds since less air is reaching alveoli. Next, ABG might reveal arterial pH of 7.35 or less and PCO2 above 45 millimeters of mercury, indicating respiratory acidosis and hypercapnia, while spirometry usually shows PEF less than 40%. Finally, pulse oximetry might demonstrate saturation below 90%. If this is the case, suspect acute asthma exacerbation or even status asthmaticus, and immediately administer supplemental oxygen at 100% FiO2, inhaled bronchodilators, including a short-acting muscarinic antagonist like ipratropium and a short-acting beta agonist or SABA like albuterol, as well as systemic corticosteroids, either oral or IV. If the patient doesn't respond to treatment, you can also give a single dose of IV magnesium. Lastly, in severe cases, you may even proceed with endotracheal intubation and mechanical ventilation, especially if your patient has altered mental status, cyanosis, or inability to maintain respiratory effort, as well as worsening hypercapnia and respiratory acidosis. Now, let's go back to the ABCDE assessment and discuss stable patients. First, perform a focused history and physical. Your patient is likely to report shortness of breath, coughing, and chest tightness, often triggered by allergens and exercise, and they may even have an existing diagnosis of asthma. On the other hand, physical examination often reveals tachypnea and wheezing. If this is the case, suspect asthma. or if your patient has already been diagnosed with asthma, suspect worsening of its severity. You'll want to monitor the patient's vital signs, including heart rate, blood pressure, respirations, and oxygen saturation. Finally, provide supplemental oxygen to maintain an oxygen saturation above 90%. The next step in patient management is to obtain spirometry, including FVC and FEV1, to confirm the diagnosis. FVC, or forced vital capacity, is the maximum amount of air a person can forcibly exhale from their lungs after a maximum inhalation, while FEV1 is the volume of air exhaled during the first second of this forced exhalation. Now, here's a clinical pearl to keep in mind. Spirometry can be performed with a simple handheld spirometer. First, have your patient take a maximal breath in, then forcibly exhale into the spirometer until all of the air is emptied from their lungs. This will generate a flow volume loop, which will differentiate between obstructive and restrictive patterns of lung disease. Now that you've completed spirometry, calculate the patient's FEV1 to FVC ratio. If the ratio is within normal range, or even elevated for the patient's age, consider an alternative diagnosis. On the other hand, if the ratio is below normal range, suspect an obstructive lung disease, which includes asthma. But this is not enough to confirm the diagnosis, so your next step is to perform bronchodilator response or reversibility, or BDR testing. BDR testing consists of giving an inhaled dose of ASABA, followed by repeat spirometry, paying particular attention to the FEV1. If BDR testing reveals an improvement in FEV1 of 12% or more after SABA administration, you can make a confident diagnosis of asthma. On the other hand, if BDR testing reveals an improvement of FEV1 of less than 12% after SABA administration, then it's not considered significant. Still, to confidently rule out asthma, you'll need to perform further investigations, such as fractional exhaled nitric oxide testing, bronchial provocation testing, exercise challenge testing, or demonstration of peak expiratory flow variability on serial testing over the course of 2 weeks. If no reversibility of airway obstruction is evident on additional testing, consider an alternative diagnosis. However, if reversibility is present, then you can confidently diagnose asthma. Now, once you make the diagnosis of asthma, the next step is to assess symptom severity, which will help define the intensity of treatment. Based on asthma manifestations over the previous month, asthma symptoms can be classified as well-controlled, partly controlled, or poorly controlled. To determine the type, ask the following questions. First, ask your patient if they have been having daytime asthma symptoms more than twice per week. Next, determine if asthma symptoms have awakened them at night. Also, ask if they have been using a SABA inhaler to relieve asthma symptoms more than twice per week. Finally, ask your patient whether or not their asthma symptoms are persistent and limit their activities. Now, determine the intensity of treatment by the number of yes and no responses your patient gives to these questions. To start off, well-controlled asthma is when the answer to all of these questions is no. Patients with well-controlled asthma can be started on Step 1 or Step 2 therapies. Step 1 therapy is a low-dose inhaled corticosteroid, or ICS, and a long-acting beta agonist, or LABA, used in a combination inhaler known as an ICS-LABA as a reliever on an as-needed basis only. Step 2 therapy is an ICS used on a daily basis as a controller medication. No matter which option is chosen, ASABA is also commonly prescribed as a reliever medication. On the other hand, if your patient answers yes to one or two of these questions, their asthma is partly controlled. In this case, start your patient on Step 3 therapy, which consists of a low-dose ICS-LABA daily as a controller medication, with ASABA commonly prescribed as a reliever medication. Finally, if your patient answers yes to 3 or 4 of these questions, their asthma is poorly controlled, so you should start them on Step 4 or Step 5 therapies. Step 4 therapy is a medium-dose ICS-LABA used on a daily basis as a controller medication, whereas Step 5 therapy includes a high-dose ICS-LABA used on a daily basis as a controller medication. In severe cases, consider adding a long-acting muscarinic antagonist, or LAMA, or even biologic therapy. No matter which option is chosen, ASABA is also commonly prescribed as a reliever medication. Now, here's a clinical pearl to keep in mind. Asthma is a variable disease, meaning it can be triggered by many environmental variables and complicated by other risk factors and disease processes. These include smoking, exposure to smoke or other respiratory irritants, comorbidities such as allergic rhinitis and obesity, and prior asthma exacerbations in the past year. Sometimes asthma may even decompensate or even improve over time in the absence of an identifiable trigger. For these reasons, you should reassess your patient periodically, both clinically and by repeating spirometry. Okay, as a quick recap, if you suspect asthma, first you should determine whether or not your patient is stable or unstable. If they are unstable, suspect asthma exacerbation and immediately start your patient on supplemental oxygen, inhaled SAMA like ipratropium, and SABA like albuterol, and systemic corticosteroids. Unresponsive cases may get IV magnesium, while severe cases might require endotracheal intubation and mechanical ventilation. On the other hand, if your patient is stable, obtain spirometry and calculate the patient's FEV1 to FVC ratio. If the ratio is within the normal range or elevated, consider an alternative diagnosis. On the other hand, if the ratio is below the normal range, suspect an obstructive respiratory condition and proceed with BDR testing. FEV1 improvement of less than 12% requires further investigations. If additional testing reveals no reversibility of airway obstruction, consider an alternative diagnosis. However, if reversibility is present, then you can confidently diagnose asthma. On the other hand, if BDR testing reveals FEV1 improvement of 12% or more, you can also make a confident diagnosis of asthma. Either way, your next step is to assess the patient's symptom severity and determine the type of asthma. Individuals with well-controlled asthma should be started on Step 1 or Step 2 therapies. Step 1 therapy includes ICS-LABA on an as-needed basis only, while Step 2 is an ICS used on a daily basis. On the other hand, patients with partly controlled asthma require Step 3 therapy, which consists of a low-dose ICS-LABA daily. Finally, individuals with poorly controlled asthma should be started on Step 4 therapy, which includes medium-dose ICS-LABA, or Step 5 therapy, which includes high-dose ICS-LABA. In severe cases, consider adding a LAMA, or even biologic therapy. Finally, no matter which step is chosen, ASABA could also be prescribed as a reliever medication.
Asthma is an episodic, chronic respiratory disorder characterized by airway obstruction caused by inflammation and hyperresponsiveness of the bronchial smooth muscle. The two golden words in asthma are reversible, which means that the obstruction can virtually disappear with medications like bronchodilators, and inducible, which means the obstruction can happen in response to a variety of stimuli, including allergens like house dust mites, pet animal dander like cat dander, and pollen, or irritants like tobacco smoke, respiratory tract infections like a common cold or pneumonia, cold or dry air, and even emotional stress. Now, atopy is the genetic predisposition of an individual toward developing IgE antibodies to otherwise harmless environmental antigens, making that individual strongly predisposed to developing 3 allergic disorders: eczema or atopic dermatitis, allergic rhinitis, and asthma, collectively coined the atopic triad. Because of this genetic component, asthma is usually diagnosed in early childhood, and may or may not carry on into adulthood. So let's say a genetically predisposed child is exposed to a potential allergen for the first time. First off, dendritic cells take up the allergen and present it to a type 2 helper T cell, or Th2 cell. In asthma, Th2 cells make the mistake of thinking this harmless antigen is an allergen, so they release cytokines that stimulate B cells to make IgE antibodies. IgE antibodies then prime mast cells, which cautiously anticipate the next event. When the child is re-exposed to the allergen, the mast cells spill out vasoactive mediators like histamine and leukotrienes, which cause bronchoconstriction and inflammation. Once the child is no longer exposed to the allergen, the immune system relaxes, and everything goes back to normal until the next event. Now, not all asthma episodes are triggered this way by an allergen. A unique form of asthma is aspirin-sensitive asthma, which is characterized by the triad of asthma, nasal polyps, and sensitivity to aspirin, or NSAIDs. Aspirin opposes prostaglandin production, and tips the balance between prostaglandins and leukotrienes in favor of increased leukotriene production, which promotes smooth muscle contraction of the airways. Alright, so patients with asthma have intermittent episodes of dry cough, chest tightness, and shortness of breath. Some patients have just a single symptom, like cough, making the diagnosis more difficult. These symptoms may occur at any time of the day, but symptoms occurring or worsening at night is characteristic of asthma. On auscultation, there will likely be wheezing during expiration, because that's when the airways collapse and become narrow. Percussion might reveal hyperresonance, which indicates that the bronchoconstriction has led to air trapping and hyperinflation. Severe episodes are ones where a patient struggles to breathe. They might only be able to speak in short phrases, and might need to use accessory muscles like the scalene muscles of the neck, or the intercostal muscles of the ribs to help with breathing. But as the saying goes, all that wheezes isn't asthma. For example, chronic obstructive pulmonary disease, or COPD, can also cause wheezing, but it's more common in the older patient who smokes. And in COPD, the symptoms are often irreversible, because there are permanent changes to the architecture of the lungs. Another one is aspiration of a foreign body, which might obstruct an airway and cause wheezing in one area of the lungs. This usually happens in young children, and there's often a sudden onset of wheezing and cough along with the history of the child being unobserved or potentially swallowing something. Bronchiolitis, or inflammation of the small bronchioles, is often seen in children less than 2 years of age, and presents with acute cough, wheeze, and shortness of breath, following an upper respiratory tract infection like a common cold. Gastroesophageal reflux disease, or GERD, can also mimic asthma, with symptoms like chronic cough and wheezing. However, the patient is often an obese adult, and symptoms often improve with proton pump inhibitors. Allergic bronchopulmonary aspergillosis, or ABPA, is an allergic response to aspergillus antigens, and usually happens in the setting of asthma or cystic fibrosis. ABPA presents with wheezing and high serum IgE levels and eosinophil counts. However, chest radiographs often show recurrent pulmonary infiltrates. Finally, there's Churg-Strauss syndrome, which is a small vessel vasculitis that's associated with eosinophilia and wheezing, but patients also have skin purpura and peripheral neuropathy. Okay, so when asthma is suspected, the first step in diagnosis is conducting pulmonary function tests, or PFTs. The most important measurement are the forced vital capacity, or FVC, which is total volume of gas exhaled after a forced maximum inspiration, and the forced expiratory volume at 1 second, known as the FEV1, both of which are decreased in asthma. Now, because asthma is an obstructive lung disease, the FEV1 is decreased to a greater degree than the FVC, so the ratio of FEV1 to FVC is usually less than 80%. Also, because asthma is episodic in nature, the PFTs are only abnormal when the patient is having symptoms. If a person is symptomatic, the next step is to give a bronchodilator like albuterol, which reverses the PFT measurements back toward normal, confirming the diagnosis of asthma. This is known as the reversibility test. A significant reversal is defined as an increase in the FEV1 by more than 12% from baseline. If the reversal is less than 12% after giving a bronchodilator, then the patient is less likely to have asthma. Now, if you do PFTs on asymptomatic patients, they'd be normal, since asthma is an episodic disease. So in this case, we try to induce asthma symptoms by performing the methacholine challenge test. Methacholine is like acetylcholine, so it binds to muscarinic receptors on bronchial smooth muscles, causing mild bronchoconstriction. In a healthy individual who doesn't have asthma, the bronchoconstriction is negligible and does not cause a significant change in PFT measurements. But because an asthmatic patient's bronchial smooth muscle is hyperresponsive, methacholine causes a 20% decrease in their FEV1 from baseline. Remember the golden asthma words: reversible and inducible. Now, some additional tests are not specific to asthma, but they might help with diagnosis. A complete blood count, or CBC, might show an increased eosinophil count. Serum IgE levels might also be increased. And skin testing might help identify specific allergens that the patient can subsequently avoid. That involves injecting small quantities of known allergens into the patient's skin, and then observe to see if the immune system overreacts to it. Okay, so after diagnosing asthma, the next step is to determine how bad it is. Asthma severity is classified as intermittent, mild persistent, moderate persistent, or severe persistent, based on 5 parameters: the frequency at which a patient experiences symptoms, the frequency at which the patient experiences nighttime symptoms, the need for a SABA to control symptoms, the FEV1 in between exacerbations, and the degree to which the asthma interferes with the patient's normal daily activities, like going to work. Children less than 5 years of age can't usually follow PFT instructions, so the FEV1 parameter is eliminated. Now, intermittent asthma is diagnosed if there are less than 2 symptomatic episodes per week, nocturnal symptoms less than 2 times per month in those older than 5 years and absent in those younger than 5 years, a need for SABA less than 2 days per week, an FEV1 more than 80%, and no interference with normal activity. Mild persistent asthma is diagnosed if there are symptoms 2 or more times per week, but not every day. Nocturnal symptoms 3 or 4 times per month in those older than 5 years, and 1 or 2 times per month in those younger than 5 years. A need for SABA more than 2 days per week, but not more than once per day. An FEV1 more than 80%, and a minor limitation in activity. Moderate persistent asthma is diagnosed if there are symptoms every day, so 7 times a week. Nocturnal episodes 1 or more times per week, but not every night in those older than 5 years, and 3 or 4 times per month in those younger than 5 years. A need for SABA every day, an FEV1 between 60% and 80%, and moderate limitation with normal activity. Severe persistent asthma is diagnosed if there are symptoms throughout the day. Nocturnal symptoms nearly every night in those older than 5 years, and 1 or more times per week in those younger than 5 years. A need for SABA several times in a day, an FEV1 less than 60%, and extreme limitation in normal activity. As the severity of the asthma escalates, so does the complexity of the treatment plan, specifically the type of long-term treatment the patient requires. In terms of medications, the first class are bronchodilators, which include short-acting beta agonists, or SABAs, like albuterol, long-acting beta agonists, or LABAs, like salmeterol or formoterol, and long-acting muscarinic antagonists, or LAMAs, like tiotropium or ipratropium bromide. The second class are anti-inflammatory medications, which include inhaled corticosteroids, or ICS, like budesonide or fluticasone, leukotriene antagonists, like montelukast and xyluton, and oral corticosteroids, like prednisone. The third and final class of medications are mast cell stabilizers, like cromolyn. Now, in total, there are 6 steps, or strategies, in the treatment ladder of asthma, and patients are started on a step based on their severity and either stepped up or down based on their response to the treatment. Step 1 involves the use of a SABA as and when needed, which is usually to control the acute exacerbations. In Step 2, along with a SABA when needed, a low-dose ICS is also added on an as-per-need or daily basis. Alternatively, a leukotriene antagonist or cromolyn might be used daily in place of ICS. Step 3 involves the use of combination of low-dose ICS and the LABA, formoterol, daily and as per need. Alternatively, a SABA may be used when needed, with a medium-dose ICS daily, or low-dose ICS-LABA combination daily, or low-dose ICS plus LAMA or leukotriene antagonist daily. Step 4 involves the use of a medium-dose ICS-formoterol combination, daily and as per need. Alternate options include using a SABA when needed with a medium-dose ICS-LABA combination daily, or medium-dose ICS plus LAMA or leukotriene antagonist daily. Step 5 involves the use of a SABA when needed, with a medium to high-dose ICS-LABA combination plus a LAMA daily. Alternate options include a SABA when needed, with medium to high-dose ICS-LABA combination daily, or a high-dose ICS plus leukotriene antagonist daily. Finally, Step 6 involves the use of a SABA when needed with a high-dose ICS-LABA combination plus oral systemic corticosteroids. Now, going back to the severity classification of asthma, intermittent asthma is managed with Step 1 alone, and the starting point for managing mild persistent asthma is Step 2. Moderate persistent asthma is Step 3, and severe persistent asthma is Step 3 in those younger than 5 years, and Step 4 or 5 in those older than 5 years. In patients with other allergic symptoms like allergic rhinitis or eczema, who might have an elevated serum IgE, the monoclonal antibody omalizumab can target IgE, providing additional benefits to patients who are already on high-dose inhaled corticosteroids and a LABA. Finally, if the asthma is refractory to these medications, then the treatment is moved up to Step 6, which includes systemic oral corticosteroids. Oral corticosteroids are only used as a last resort, because unlike inhaled corticosteroids, they might have adverse systemic effects, including osteoporosis, cataracts, hyperglycemia, adrenal suppression, and fat redistribution. Now, patients are usually reassessed after 4 to 6 weeks of starting therapy, and if the asthma isn't controlled, then they may be stepped up the treatment ladder. If the asthma is controlled, then the same step is continued for 3 months. And if the asthma still remains well controlled, then an attempt might be made to step down the treatment ladder. But before considering changing a patient's treatment plan, it's important to consider the fact that a patient is either not taking their medication or they're not using their inhaler correctly. Other patients might be suffering from adverse effects of inhaled corticosteroids, like hoarseness or oral candidiasis, which might be the reason they aren't using it. Finally, other medications like leukotriene receptor antagonists and mast cell stabilizers are helpful in atopic patients, but are never first line. Now, all of this medication escalation works great in a clinical setting, but when there's an acute exacerbation in an emergency room setting, there's no time to do PFTs, and some patients are so short of breath they can barely talk, let alone give an elaborate history. That's why, in an acute asthma exacerbation, the priority is to relieve the current episode, and figure out if a patient needs to head home, to the inpatient floor, or to the intensive care unit, the ICU. The best initial test is a peak expiratory flow rate, or PEFR. The PEFR is essentially the fastest and the hardest a person can exhale after a full inspiration. PEFR is kind of like a bedside mini PFT. Not quite as reliable, but super useful in an emergency setting. A normal PEFR is typically greater than 70% of the predicted peak flow for the patient's age. Now, in the clinic setting, we previously classified the severity of asthma based on symptom frequency, FEV1, and activity, and that determined the patient's long-term treatment. On the other hand, in the acute setting, asthma exacerbations can be classified into mild, moderate, severe, life-threatening, and near-fatal, based on the severity of the current symptoms and the PEFR. Now, an additional test is an arterial blood gas, or ABG, and it's useful in a severe or life-threatening exacerbation to determine if the patient is retaining carbon dioxide, which can be a sign of impending respiratory failure. Mild exacerbations are characterized by symptoms only with activity, and a PEFR greater than 70%. Patients with mild exacerbations rarely come to the emergency department, because most of the time their symptoms go away after using an inhaled SABA. Moderate exacerbations are characterized by symptoms that don't readily improve with a SABA, and a PEFR between 40 and 70%. Mild and moderate exacerbations usually don't require an ABG. Severe exacerbations are characterized by any one of the following: a PEFR between 25 and 40%, a respiratory rate greater than 25 breaths per minute, a heart rate greater than 110 beats per minute, or if the patient is unable to complete sentences. Moderate and severe exacerbations show a low partial arterial pressure of carbon dioxide, or PaCO2, on an ABG, which is normally between 33 and 45 millimeters of mercury. This happens because the patient is breathing really fast and blowing a lot of CO2 out. Life-threatening exacerbations are characterized by any one of the following: a PEFR less than 25%, an oxygen saturation less than 92%, an altered mental status, absence of wheezing, and a normal PaCO2 on the ABG. Now you might be thinking, no wheezing and a normal PaCO2 sounds normal. But a silent chest in the context of worsening asthma is a terrible sign, because it means the obstruction is now complete. In other words, there's literally no airflow to even create that musical wheezing sound. Also, if a patient is having an asthma exacerbation, we expect the PaCO2 to decrease. But if the PaCO2 is normal, that means they're tiring out, and the patient is beginning to retain CO2. Finally, a near-fatal exacerbation is when all those medications don't work, and patients have an elevated PaCO2 and can no longer breathe on their own, necessitating ventilatory support. Generally speaking, a chest X-ray in asthma is usually either normal or shows hyperinflated lungs, but in an acute setting, it's obtained to rule out an underlying cause of the asthma exacerbation, like pneumonia. But the idea is not to wait for ABGs and chest X-rays in an exacerbation. Treatment begins immediately with oxygen using a non-rebreather mask, with the target oxygen saturation being above 92%. Right away, it's important to start a SABA like albuterol, with a nebulizer or with a metered dose inhaler to reverse the bronchoconstriction. Also, ipratropium bromide might be given in cases of severe exacerbations. Both are typically given as 3 doses given 20 minutes apart. Oral or intravenous systemic corticosteroids should be given to reverse the inflammation. If the patient isn't responding to the bronchodilators, or if they're having a life-threatening or near-fatal exacerbation, intravenous magnesium sulfate might be added. Magnesium sulfate works by inhibiting calcium influx in the smooth muscles of the bronchi, causing bronchodilation. Finally, unless the patient actually has a concomitant pneumonia evident on chest X-ray, routine antibiotics are not indicated in asthma exacerbations. Now, after providing treatment in the emergency department, if the PEFR is greater than 70% and the patient's symptoms have completely reversed, they can go home. But before sending your patient packing, make sure you arrange a follow-up plan in the clinic to see if their asthma severity is worsening, and to check if they know how to use their inhaler. If the PEFR is between 50 and 70% and the symptoms are incompletely reversed, then the patient can be admitted to floor, where the patient can be observed, and treatment can be continued. If the PEFR is less than 50% and the symptoms are not improving, then the patient should be taken to the ICU, where the patient might need positive pressure ventilation or intubation in the most extreme situations. Finally, when discharged following an exacerbation, all patients are put on a brief course of oral corticosteroids for 5 to 10 days, which significantly reduces the risk of another exacerbation within the next 2 weeks. Alright, as a quick recap. Asthma is a chronic condition with reversible airflow obstruction, bronchial hyperresponsiveness, and an underlying inflammation, all of which lead to recurring symptoms like wheezing. Based on symptoms, patients are categorized as having intermittent, mild persistent, moderate persistent, or severe persistent asthma. Treatment plans involve 6 steps, which initially include a short-acting beta agonist. As the steps go up, stronger medications like inhaled corticosteroids, long-acting beta agonists, and finally systemic oral corticosteroids are added. Asthma exacerbations are classified into moderate, severe, life-threatening, and near-fatal. Initial treatment includes nebulized bronchodilators like albuterol and ipratropium, as well as systemic corticosteroids. Asthma comes from the Greek word for panting, which makes sense because it causes chronic inflammation of the airways, making them narrow and more difficult to breathe through. People with asthma can have asthma exacerbations or asthma attacks, which are usually triggered by something in the environment which causes immune cells to generate inflammation in the lungs, which can make them even narrower and potentially be life-threatening. So if we take a look at the lungs, you've got the trachea, which branches off into the right and left bronchi, and then continues to branch into thousands of bronchioles. In the bronchioles, you've got the lumen, the mucosa, which includes the inner lining of epithelial cells, as well as the lamina propria, and the submucosa, which is where the smooth muscle lives. The molecular pathway that leads to asthma is actually pretty complex, but it's often initiated by an environmental trigger. In asthma, there's often an excessive reaction from type 2 helper cells, or Th2 cells, against specific allergens. Th2 cells are an immune cell subtype, which are known to be involved in asthma, as well as atopic dermatitis and allergic rhinitis, making up what's called the atopic triad. What can happen with asthma is allergens from environmental triggers, like cigarette smoke, are picked up by dendritic cells, which present them to Th2 cells, which produce cytokines like interleukin 4 and interleukin 5, leading to a number of the features of asthma. For example, interleukin 4 leads to the production of IgE antibodies, which coat mast cells and stimulates them to release granules containing things like histamines, leukotrienes, and prostaglandins. Interleukin 5, on the other hand, activates eosinophils, which promote an immune response by releasing more cytokines and leukotrienes. In this case, since IgE antibodies are being produced, this is an example of a type 1 hypersensitivity reaction. This leads to two series of events. Early on, minutes after exposure to the allergen, smooth muscle around the bronchioles start to spasm, and there's increased mucus secretion. This narrows the airways, making it difficult to breathe, and this is why asthma is considered to be a type of obstructive pulmonary disease. There's also an increase in vascular permeability and recruitment of additional immune cells from the blood. These immune cells, especially eosinophils, release chemical mediators that physically damage the endothelium of the lungs. Initially, these inflammatory changes are completely reversible, but over the years, irreversible changes start to take place. Edema, scarring, and fibrosis build up, leading to thickening of the epithelial basement membrane, which permanently reduces the airway diameter. Although the specific causes of asthma are ultimately unknown, it's thought to be caused by a combination of genetic and environmental factors, since certain genes have been identified that increase the risk of developing asthma, and having a family history of asthma seems to increase the risk as well. For environmental factors, there's the hygiene hypothesis, which suggests that reduced early immune system exposure to bacteria and viruses might actually increase the risk of later developing asthma, possibly by altering the overall proportion of immune cell subtypes. In general, causes of childhood asthma diagnosed before age 12 are thought to be due to a stronger genetic influence, whereas later onset asthma is more likely to be due to environmental factors. Now, the triggering substance that leads to an asthma attack can differ from person to person, but some common ones include air pollution like cigarette smoke and car exhaust, as well as allergens like dust, pet dander, cockroaches, and mold. Medications like aspirin and beta blockers have also been known to trigger symptoms in some individuals with asthma. That said, symptoms of asthma include coughing, a feeling of chest tightness, dyspnea or difficulty breathing, and wheezing, or a high-pitched whistling sound that usually happens during exhalation. Occasionally in the sputum, there might be Kirschmann spirals, which are spiral-shaped mucus plugs or basically elongated mucus casts from the small bronchi of people with bronchial asthma. Mucus plugs can be particularly dangerous because they not only block exchange of air, but they also block inhaled medications from getting to the site of inflammation. The mucus might also have Charcot-Leyden crystals, which are shaped like needles and are formed by the breakdown of eosinophils. Now, asthma can be classified according to the frequency of symptoms, in particular nighttime and early morning symptoms, the FEV1 or forced expiratory volume in 1 second, the PEFR, or peak expiratory flow rates, both of which measure the amount of obstruction in the airways, and finally, how often a person is using asthma medication to help with the symptoms. From least to most severe, the types of asthma are intermittent asthma, mild persistent asthma, moderate persistent asthma, and finally, severe persistent asthma. While there's no cure for asthma, there are treatments available that can help manage the symptoms and prevent the development of an asthma attack. First, people with asthma should avoid or minimize contact with triggering substances by vacuuming, removing carpets and rugs, and changing the environmental conditions, like, for example, drying out a room in the case of molds that grow well in moist areas. There are also a number of medications that can reduce the symptoms of asthma. Bronchodilators like short-acting beta-adrenoceptor agonists and anticholinergic medications are often administered through emergency inhalers. These fast-acting medications cause the smooth muscles in the lungs to relax and therefore dilate the airways, opening them up so that the person can breathe. Individuals with more severe forms of asthma might need additional treatments, like daily corticosteroids, long-acting beta-adrenoceptor agonists, or leukotriene antagonists. In very severe cases, intravenous corticosteroids, magnesium sulfate, and oxygen therapy might be needed. Alright, as a quick recap, asthma is characterized by chronic inflammation in the lungs, as well as asthma exacerbations or attacks, where certain triggers start up more inflammation, which leads to smooth muscle spasms and mucus production, both of which make it hard to breathe.
A food allergy is a medical condition where there's an abnormal immune reaction to some foods. Now, a variety of food proteins can cause food allergies, but the most common are known as the Big Eight. These include proteins within milk, eggs, peanuts, tree nuts, seafood, shellfish, soy, and wheat. Food is essential for life, and normally food doesn't cause an allergic reaction. In fact, the process that allows for that is called oral tolerance. So let's break down how that works. Normally, when food travels through the stomach and intestines, the proteins within them are broken down by gastric acid and proteases into tiny fragments called oligopeptides, small strings of amino acids. These oligopeptides reach the Peyer's patches, which are bits of tissue along the intestinal wall where M cells live. M cells are intestinal epithelial cells in the gut that grab protein fragments from the intestines and then transfer them to antigen-presenting cells like dendritic cells. Dendritic cells present them on their surface to a nearby helper T cell. The protein fragments are presented by the dendritic cell using an MHC class II molecule, which is basically a serving platter for the helper T cells. The helper T cell is key because it largely controls the immune response. Now, here's the catch. Even if a helper T cell binds to that oligopeptide, another type of T cell, called a regulatory T cell, can release cytokines so that the helper T cell undergoes anergy. Anergy is a bit like turning off that helper T cell so it doesn't induce an immune response. In other words, regulatory T cells release cytokines in the lining of the intestines to help prevent the helper T cells from ever getting stimulated by food. Now, in food allergy, this process doesn't work properly. An allergic reaction towards food happens in two steps: a first exposure, or sensitization, and then a subsequent exposure, which usually gets a lot more serious. So let's say a person eats shrimp for the first time, and for some reason, the helper T cell is able to generate an immune response toward the proteins within shrimp. Now, once shrimp proteins reach the small intestines, M cells grab the shrimp proteins and transfer them to dendritic cells that start to present shrimp proteins on their MHC class II molecules to helper T cells. The helper T cells that recognize this antigen will bind to it with their T cell receptors, and based on the cytokines that are floating around, they mature into type II helper T cells, or Th2 cells. Th2 cells release a variety of cytokines, like interleukin 4. This interleukin 4 gets nearby B cells that also recognize the protein to switch from making IgM antibodies to making IgE antibodies, which are specific to the shrimp protein. These shrimp-specific IgE antibodies are able to attach to the surface of mast cells and basophils. At this point, the sensitization phase has come to an end, and mast cells and basophils are ready for action. Now, let's say that same person eats shrimp again a few months later. That's the second exposure that leads to a type 1 hypersensitivity reaction. Specifically, the IgE on the surface of the sensitized mast cells and basophils will bind to the shrimp antigen. When two IgE antibodies that are near one another both bind to the same antigen, it's called cross-linking. When two IgE antibodies cross-link on the surface of a mast cell or basophil, it sends a signal down into the cell, which makes that cell degranulate and release a bunch of pro-inflammatory molecules, like histamine. This histamine gets into the intestinal tissue as well as into the blood. The histamine often binds to H1 receptors, stimulating free nerve endings near the skin, which causes hives and itching. It also causes blood vessel dilation and increases the permeability of the walls of the blood vessel, which causes fluid to leak out into the space between the cells, which causes edema and swelling of the lips. In a severe case, this can cause so much fluid to leak out of the vessels that it leads to hypotension. Histamine can cause the smooth muscles around the bronchi in the lungs to contract, which means that the airways get smaller and it makes breathing more difficult. All of this happens within minutes to hours of the second exposure. And when all of these symptoms occur and breathing is affected, it's called anaphylaxis. And sometimes there can be a biphasic reaction, which is when the symptoms improve, but then worsen again over the course of a few hours. Now, there's also a non-IgE mediated food allergy, which includes a range of gastrointestinal food allergies that affect the gut. There's also food protein-induced enterocolitis syndrome, or FPIES for short, where the small intestine and the colon get inflamed, mostly due to cow's milk in infants. Other causes include celiac disease, where people who are allergic to gluten have their small intestine inflamed and damaged. Non-IgE mediated food allergy doesn't involve IgE antibodies, obviously, and typically it occurs hours or days after the exposure. The way non-IgE mediated food allergy works is still not well understood, but it's believed that since the gut's immune system is still maturing early on, it tends to overreact towards some food proteins, like the ones found in cow's milk. The symptoms of the non-IgE mediated type are mainly gastrointestinal ones, like abdominal pain, reflux, constipation, and loose stools. Finally, some people develop mixed IgE and non-IgE mediated food allergies, and therefore they experience symptoms from both types. There are two main types of tests to determine if a person has food allergies. First, there's the skin test, where a tiny amount of the food the person is allergic to makes contact with a wound on the skin. If an allergic reaction occurs, a red itchy bump appears on the skin. Second, there are blood tests that can determine if there are antibodies in the blood that are specific to any particular foods. This helps diagnose the IgE-mediated type. Diagnosing the non-IgE-mediated type is much more challenging, and it's mainly based on the dietary history of the patient. The management of food allergies consists mainly of avoiding the triggering food. For milder allergic reactions, antihistamines can help reduce the allergic symptoms. Finally, if there are signs of anaphylaxis, epinephrine in the form of an EpiPen delivered straight into a muscle can be used to give an immediate dose. Alright, as a quick recap. A food allergy is a medical condition in which there's an abnormal immune reaction to certain food proteins. The most common form of food allergies is IgE mediated, but there are other frequent types like non-IgE mediated and mixed, which is a combination of the two. The diagnosis consists of a skin test and a blood test. The primary management of food allergies is basically avoiding all foods that may cause an allergic reaction.
Having a hypersensitivity means that the immune system is reacting to something in a way that damages the body rather than protecting it. There are 4 different types of hypersensitivities, and the second type, or type 2 hypersensitivity, is sometimes called cytotoxic hypersensitivity because a lot of disorders caused by this hypersensitivity involve antibody-mediated destruction of healthy cells. These disorders tend to be tissue-specific, meaning that the antibodies are generally specific to one type of tissue or organ. There are other antibody-mediated hypersensitivities that are systemic, but these are generally type 3 hypersensitivities. So our immune system is set up to fight anything that's considered non-self, right? Anything that's not self, or you. This works in large part because of a process called central tolerance, which is when developing immune cells that are self-reactive get destroyed or inactivated, whereas immune cells that aren't are allowed to survive. And this happens while they're still in their primary lymphoid organs, which is the thymus for T cells and bone marrow for B cells. This process, though, isn't perfect, and some self-reactive B and T cells will escape. These escaped self-reactive cells can then attack healthy tissue, which results in an autoimmune disease. In type 2 hypersensitivity, these escaped self-reactive B cells become activated and produce IgM, or with the help of CD4 positive T helper cells, IgG antibodies that attach to antigens on host cells. And there are 2 types of antigens involved with type 2 hypersensitivity. Intrinsic, meaning an antigen that the host cell normally makes, or extrinsic, which is an antigen from an infection or even some medications like penicillin that gets attached to the host cell. Alright, so let's say a drug like penicillin binds to a red blood cell. Well, it becomes an extrinsic antigen. An IgG, or more rarely, an IgM antibody that's penicillin specific might bind to the penicillin molecule, creating an antigen-antibody complex. Now it's worth mentioning that antigen-antibody complexes can happen in the course of a normal infection, but it's when an antibody is complex to host tissue that things start to become a problem. The first cytotoxic mechanism of type 2 hypersensitivity is activation of the complement system. The complement system is a family of small proteins that work in an enzymatic cascade to fight off bacterial infections using a variety of mechanisms. In this case, the IgG or IgM antibodies activate complement proteins, which ultimately will kill the red blood cell bound to penicillin, which is complexed now with IgG or IgM. Alright, so the process gets started with C1, the first of the complement proteins, which binds to the Fc portion of the antibody. C1 then engages other members of the complement family, C2 through C9, some of which are activated by being cleaved or chopped by an enzyme. The cleaved fragments, C3a, C4a, and C5a, act as chemotactic factors, meaning they attract certain cells, in this case neutrophils. Once neutrophils join the party, they degranulate or dump a bunch of enzymes like peroxidase, myeloperoxidase, and proteinase 3, which all help generate little oxygen radicals that are highly cytotoxic to cells and can cause tissue damage. When it comes to drug reactions like penicillin, type 2 hypersensitivity can result in hemolytic anemia, sometimes called autoimmune hemolytic anemia, as well as thrombocytopenia or neutropenia, since these are all blood cell types that are often affected. This mechanism is also involved in diseases like Goodpasture syndrome, where antibodies bind to intrinsic antigens on collagen of the basement membrane in their glomeruli in the kidney, or their alveoli in their lungs, rather than extrinsic antigens in the penicillin example. The second cytotoxic mechanism requires us to follow the complement system through to the end. That said, C5b, C6 through C8, and a bunch of C9 come together to form the membrane attack complex, or MAC. The MAC attacks the cell by inserting itself into the cell membrane, punching a hole or creating a channel that allows fluid and molecules to flow in and out of the cell. And this is not good for the cell's overall health, right? Because due to the osmotic difference, fluid rushes into the cell, and the cell swells and eventually bursts, called cell lysis, and it dies. And that's the second mechanism, and this is where the name cytotoxic comes from. In our example, if you suspect autoimmune hemolytic anemia, the antibody in question can be detected using a direct Coombs test. In the direct Coombs test, the person's red blood cells are separated from the plasma and then mixed with Coombs reagent, which is anti-human globulin, basically an antibody against human antibodies. If the red blood cells agglutinate or clump up, that means that they probably had antibodies on their surface. Besides a direct test, there's also an indirect Coombs test, which is usually done to check for blood group incompatibility. For an indirect Coombs test, the patient's serum is mixed with laboratory red blood cells that have known antigens on their surface, and then once again mixed with Coombs reagent. If there is red blood cell agglutination, that indicates the presence of antibodies or complement in the serum. The indirect Coombs test is done to determine if you have antibodies before you're exposed to the antigen. For example, this could be like a mismatched blood transfusion, or a second pregnancy with a mismatched Rh factor between the mother and the child. Alright, so the third cytotoxic mechanism of type 2 hypersensitivity happens when IgG antibodies coat a blood cell that are bound by C3b, another one of those complement protein fragments. At this point, we say that the cell has been opsonized, which means it's targeted for phagocytosis, which is where they get engulfed and destroyed by phagocytes like macrophages and neutrophils. Once opsonized, the antibody-antigen complex in the cell it's attached to encounters a phagocyte in the body's blood filtration organ, the spleen. And the phagocyte targets the cell by binding to the Fc tail of the antibody or the C3b bound to the IgG. Then it engulfs and destroys the cell. Alright, so the last three mechanisms involve the complement system in one way or another. The last couple mechanisms are a little different. So the fourth mechanism is called antibody-dependent cell-mediated cytotoxicity, or ADCC. In this case, the bound antigen-antibody complex gets recognized by immune cells called natural killer cells. The natural killer cell recognizes the Fc tail of the antibody and releases toxic granules. These granules contain perforins, which, just like the MAC, form pores in the cell, except that this time the pore also allows entry of enzymes that are like these silent assassins called granzymes, as well as granulysin, which work together to cause cell death in an apoptotic or quiet death sort of way, such that there's no surrounding inflammation. Okay, so far all the mechanisms have led to cell death or cytotoxicity, right? There are, though, non-cytotoxic type 2 hypersensitivities as well, where the antibody just sort of disrupts function, called antibody-mediated cellular dysfunction. Sometimes when an antibody binds to its antigen, it just sort of gets in the way. When this happens, it can change the way the cell is supposed to function. This is the case in the autoimmune disease myasthenia gravis, where antibodies specific for the acetylcholine receptor in muscles simply blocks the binding of acetylcholine, which causes the muscles to not get stimulated and progressively weaken over time. This mechanism is also involved in Graves' disease, where antibodies target receptors that stimulate thyroid hormone production. But in this case, they not only get in the way, they actually activate the receptors, causing overproduction of thyroid hormone, or hyperthyroidism. And there you have it, a handful of different ways that antibody binding to cells can cause them to get destroyed or become less effective. The important things to remember about type 2 hypersensitivity is that they're antibody mediated, they generally lead to cytotoxicity, and they're tissue specific. Thanks for watching. You can help support us by donating on Patreon, or subscribing to our channel, or telling your friends about us on social media. Goodpasture syndrome is an autoimmune disease that primarily affects two organs, the lungs and the kidneys. It causes inflammation and eventually bleeding in the lungs, which leads to hemoptysis, or coughing up of blood, and hematuria, or blood in the urine, a pattern first recognized by the pathologist Dr. Ernest Goodpasture. To understand Goodpasture syndrome, let's start by thinking about the basement membrane, which is a thin, sheet-like layer of tissue made of protein that keeps the epithelium stuck firmly to the actual organ, kind of like double-sided tape, which keeps wrapping paper stuck to the gift. This basement membrane is made up of various proteins, but the major one is collagen. And since basement membrane exists throughout every organ system, it's no wonder that collagen is the most abundant protein in the human body. As far as proteins go, collagen's a pretty sweet-looking one, with a triple helix structure composed of 3 separate chains that are intertwined like braided hair. Each of the chains can be one of 6 types, named alpha 1 through alpha 6, and the most common form of collagen found in the basement membrane is collagen type 4, which is made by mixing and matching these 6 alpha chains. One version of type 4 collagen combines the alpha 3, alpha 4, and alpha 5 chains. Another combines 2 alpha 1s and an alpha 2. And a third version has 2 alpha 5s and an alpha 6. And this list of combinations goes on. So it turns out that the alpha 3, alpha 4, alpha 5 variant is most common in the glomerular basement membranes of the kidneys and the alveolar basement membrane of the lungs. In Goodpasture syndrome, autoantibodies bind to a specific part of the alpha 3 chain that's usually hidden deep within the folded chains. This is an example of a type 2 hypersensitivity reaction, because once these autoantibodies, usually IgG but rarely IgM or IgA, bind to the alpha 3 chain, they activate the complement system. Now, the complement system is a series of small proteins present in the blood that act like an enzymatic cascade to fight off bacterial and other pathogenic invasions. When the FAB portion of the IgG molecule inappropriately binds to the alpha 3 chain, C1, which is the first of the complement proteins, binds to the FC portion of the IgG molecule. This bound C1 is now activated, and it starts engaging other members of the complement family, C2 through C9. Some of these are activated by being cleaved or chopped by an enzyme. The cleaved fragments C3a, C4a, and C5a act as chemotactic agents, meaning they attract certain cells like neutrophils. Once neutrophils join the party, they dump a bunch of enzymes like peroxidase, myeloperoxidase, and proteinase 3, which all cause free oxygen radicals to form, which damage the basement membrane as well as the nearby endothelium and the underlying organ itself. Genetic risk factors for Goodpasture syndrome include having genes that encode a specific type of immune molecule called HLA-DR15, which is used to identify and bind to foreign molecules. Environmental risk factors, on the other hand, also play a role, and it relates back to the fact that the autoantibodies bind to a specific part of the alpha 3 chain that's usually hidden deep within the folded chains. When the collagen molecules are damaged by infection, smoking, oxidative stress, or some hydrocarbon-based solvents, as in the case of people who work in the dry cleaning industry, these antigenic regions on the alpha 3 chain get exposed to the antibodies present in the blood of genetically susceptible people. This also helps explain why Goodpasture syndrome specifically affects the kidney and the lungs. The kidney filters toxins from the blood, so as they pass through the basement membrane of the kidney, they likely expose parts of the alpha 3 chain. And similarly, the lungs get exposed to various inhaled toxic substances, like cigarette smoke, once again exposing the parts of the alpha 3 chain that leads to Goodpasture syndrome. In Goodpasture syndrome, lung symptoms usually come before kidney symptoms. Damage to the basement membrane in the lungs can cause widespread damage to the alveoli, the small air sacs where gas exchange happens between the air we breathe in and the blood, leading to a cough and hemoptysis, or blood in the sputum. The damage to the alveoli can also impair the ability of the lungs to exchange oxygen for carbon dioxide, leading to a pattern of restrictive lung disease. Damage to the basement membrane in the kidney affects its ability to filter properly, allowing blood to get into the urine, called hematuria, as well as protein to get into the urine, called proteinuria. And this fits the pattern of nephritic syndrome. Now, the best way to diagnose Goodpasture syndrome is by doing a biopsy, usually in the kidney, because that's the best studied organ in this disease. Under a microscope, you'll usually see inflammation of the basement membrane. And if fluorescent proteins that bind to the anti-basement membrane antibodies are used, they light up in a linear pattern along the basement membrane. In the past, Goodpasture syndrome was usually fatal, but aggressive treatment with corticosteroids and immunosuppressive agents, as well as plasmapheresis, which involves filtering out the fluid part of the blood or plasma, has improved the prognosis with fewer individuals developing chronic renal failure and needing dialysis. Alright, as a quick recap, Goodpasture syndrome is an autoimmune disease in which the immune system attacks the alpha-3 chain of type 4 collagen present in the basement membrane. The specific spot that gets affected is usually well hidden, but gets exposed by various toxins, which is why the disease predominantly affects the lungs and kidneys, causing symptoms like hemoptysis and hematuria.
Hey guys, this is Vince. I hope you enjoyed our video today. The script was written by Debal Sinharoy. The script was edited by Rishi Desai. The video was illustrated by myself, and of course, Tanner Marshall did the voiceover. Besides our videos, you can also check us out at our brand new subreddit page at r/osmosit, where we will be sharing some of these videos and also having discussions and those kind of things. Besides that, you can always subscribe to our channel, like and share our videos, and of course you can donate to us on Patreon. Okay, thanks a lot guys. Bye.
Myasthenia gravis is a Latin expression that literally means grave muscle weakness, which perfectly describes the weakness that happens when this autoimmune disease affects the skeletal muscles. People with myasthenia gravis might wake up feeling fine, but get progressively weaker as the day goes on, and by the end of the day they might feel very weak, sometimes even getting weaker with repetitive movements, like chopping vegetables. Myasthenia gravis can affect the extraocular muscles, which control movement of the eye as well as the eyelids. So individuals might have diplopia, or double vision, as well as ptosis, or drooping eyelids. Myasthenia gravis preferentially affects young women in their 20s and 30s, and older men in their 60s and 70s. But the cause of this odd bimodal distribution of age of onset isn't quite clear. To better understand myasthenia gravis, though, let's review normal muscle contraction, but at the cellular level. First, you've got your motor neurons that release the neurotransmitter acetylcholine at the neuromuscular junction, which then binds to nicotinic acetylcholine receptors on the muscle cell membranes. Binding of acetylcholine to its receptor activates a chain reaction in the muscle cell that ultimately results in muscle contraction. But what happens in myasthenia gravis, though? Well, remember that it's an autoimmune disease, and specifically one that's categorized as a type 2 hypersensitivity, which causes cytotoxic injury, meaning that it results in the lysis or death of host cells, which is mediated by autoantibodies, which are antibodies that are specific for our own cells or proteins. Alright, so in this case, the patient's B cells inappropriately make antibodies that bind to nicotinic acetylcholine receptors on the muscle cells. Once acetylcholine receptors are bound by the antibody, they're unable to bind the acetylcholine, and therefore they don't respond to the contract signal from the central nervous system. Anti-acetylcholine receptor antibodies can also activate the classical complement pathway. Now, the complement system is a family of small proteins that work in an enzymatic cascade to fight off bacterial infections. The activation of complement causes inflammation and destruction of the muscle cells, and reduces the amount of acetylcholine receptors on the surface. Now, a minority of people with myasthenia gravis produce another type of harmful antibody called muscle-specific receptor tyrosine kinase antibodies, which attack proteins inside the muscle cells instead of nicotinic acetylcholine receptors on the muscle cell surface, but they similarly lead to destruction of healthy cells. In very rare cases, myasthenia gravis can present as a paraneoplastic syndrome, which means that an underlying cancer like bronchogenic carcinoma or thymic neoplasm, also known as thymoma, generates an immune response which results in the generation of autoantibodies. In some cases, if certain muscles are affected, myasthenic patients can experience a myasthenic crisis, which is a life-threatening manifestation of the disease. An example of this might be a decreased function of the muscles that control breathing. The good news, though, is that treatment has been able to reduce mortality from myasthenia gravis. One type of medication is an acetylcholinesterase inhibitor, like neostigmine or pyridostigmine. Acetylcholinesterase is an enzyme that degrades acetylcholine. So acetylcholinesterase inhibitors stop acetylcholinesterase from breaking down acetylcholine, which ends up increasing the concentration of acetylcholine around the muscle cells and helps counteract the effects of acetylcholine receptor antibodies. Myasthenia gravis is also treated with immunosuppressive drugs, like prednisone, which reduce the production of harmful antibodies. Finally, a lot of people with myasthenia gravis undergo surgical removal of the thymus. This seems to reduce the muscle weakness symptoms even in people that don't appear to have any identifiable problems with the thymus gland itself. It's possible that this is because helper T cells, which originate in the thymus, help B cells to make antibodies to the acetylcholine receptor. Alright, as a quick review, myasthenia gravis is a type 2 hypersensitivity disorder where the body produces antibodies that most commonly target nicotinic acetylcholine receptors on the surface of muscle cells. The antibodies block the receptors, which means the signal to contract isn't received. Those antibodies also activate the complement pathway, which leads to muscle cell destruction. Myasthenia gravis preferentially affects young women or older men, and commonly affects the extraocular muscles, which leads to eyelid drooping or double vision, but it might affect any skeletal muscle. Thanks for watching. You can help support us by donating on Patreon, or subscribing to our channel, or telling your friends about us on social media.
Pemphigus vulgaris is a rare autoimmune skin disorder that causes blisters, or bulli, because there's separation of skin cells. Now, the skin is divided into 3 layers: the epidermis, dermis, and hypodermis. The epidermis forms the thin outermost layer of skin. Underneath is the thicker dermis layer, and finally there's the hypodermis that anchors the skin to the underlying muscle. The epidermis itself is made of multiple layers of developing keratinocytes, which are flat, pancake-shaped cells that are named for the keratin protein that they're filled with. Keratinocytes start their life at the lowest layer of the epidermis, called the stratum basale, or basal layer, which is made of a single layer of stem cells, called basal cells, that continually divide and produce new keratinocytes. Below the epidermis is the basement membrane, which is a thin layer of delicate tissue containing collagen, laminins, and other proteins. Hemidesmosomes are a protein complex that attach basal cells to the basement membrane. As keratinocytes in the stratum basale mature and lose the ability to divide, they migrate into the next layer, called the stratum spinosum. The next layer up is the stratum granulosum, then the stratum lucidum, and finally the stratum corneum. The cells of the epidermis are bound together by protein complexes called desmosomes, most of which are in the stratum spinosum. Similarly to how the skin lines the outside of the body, the mucosa lines the inside of the body, and it's named for the surface it covers. So there's the oral mucosa, nasal mucosa, bronchial mucosa, gastric mucosa, intestinal mucosa, and so forth. Mucosa is made up of one or more layers of epithelial cells that sit on top of a layer of connective tissue called lamina propria. Just like with the skin, the mucosal cells are attached to each other by protein complexes called desmosomes, And the basal cells are attached to the basal membrane by protein complexes called hemidesmosomes. Pemphigus vulgaris is a type 2 hypersensitivity reaction, which is when the immune system produces antibodies that bind to the body's own cells. More specifically, immune cells, called B cells, produce IgG antibodies that can bind to specific desmosome proteins, desmoglein 1 and 3. It's unclear what triggers this to happen, but it's thought that it happens in genetically predisposed people and gets triggered by something like a herpes virus infection or a medication, like captopril or certain antibiotics. Now, all the layers of the epidermis are rich in desmoglein 1 and 3, while mucosal cells predominantly have desmoglein 3. So, in individuals with IgG antibodies that bind to both desmoglein 1 and 3, a person develops mucocutaneous pemphigus vulgaris because it affects both the skin and the mucosa. But in individuals with IgG antibodies that only bind to desmoglein 3, a person develops mucosal pemphigus vulgaris because the mucosa is affected. But the skin isn't really affected, as there's enough desmoglein 1 to compensate for the loss. Now, when the IgG antibodies bind to desmogleins on the surface of cells, they trigger apoptosis, or programmed cell death. In that process, proteases get released, which are enzymes that break down the proteins that make up the desmosomes. The loss of desmosomes leads to acantholysis, which is the process of cells letting go of one another, and that directly leads to the formation of bulli, or blisters. Now, since hemidesmosomes aren't affected, basal cells remain anchored to the basement membrane, but separate from other cells of the epidermis, and that's called tombstoning. So, the bulli of pemphigus vulgaris are intraepidermal, meaning that they're within the epidermis, while the bulli of a similar disease, bullous pemphigoid, are subepidermal, meaning between the epidermis and dermis. Early on in pemphigus vulgaris, there can be bulli and ulcerations on the oral mucosa, but any type of mucosa can be affected. The oral lesions can be very painful and can lead to a person having difficulty with eating and drinking. The mucocutaneous form develops skin lesions as well. At first, the affected skin has flat red areas called macules, and they can appear almost anywhere on the body. Over time, the macules develop into bulli, or blisters, which eventually rupture and leave painful erosions. Sometimes the lesions can get infected, and that can worsen the pain and discomfort. A classic sign to help diagnose pemphigus vulgaris is the Nikolsky's sign, which is when lateral pressure is applied to the lesion, and that causes a split to form between the upper and lower layers of the epidermis. In other skin conditions, like bullous pemphigoid, the skin doesn't split, resulting in a negative Nikolsky's sign. In addition, a skin biopsy can be used to look for signs of acantholysis and tombstoning. Finally, direct immunofluorescence can be used. That's where antibodies marked with fluorescent molecules are used to tag the autoreactive IgG antibodies, which are attacking the epidermal cells. Treatment of pemphigus vulgaris can include both topical and systemic corticosteroids, depending on the severity of the disease. In addition, rituximab can be used. Rituximab is a monoclonal antibody which binds to B cells and inhibits the production of antidesmosomal IgG antibodies. Finally, to lessen the pain of the oral lesions, topical rinses like viscous lidocaine can be used. Alright, as a quick recap. Pemphigus vulgaris is an autoimmune skin disorder where B cells create IgG antibodies that target desmoglein 1 and 3. The destruction of these desmosome proteins leads to the formation of intraepidermal blisters in the mucosa and the skin. Symptoms include oral and skin lesions and flaccid blisters, which can be diagnosed by a positive Nikolsky's sign, skin biopsy, or direct immunofluorescence. Topical and systemic corticosteroids and rituximab can be used to treat the disease.
Having a hypersensitivity means that someone's immune system has reacted to something in a way that ends up damaging them, as opposed to protecting them. There are 4 different hypersensitivities, and the third type, or type 3 hypersensitivity reaction, happens when antigen-antibody complexes deposit in blood vessel walls, causing inflammation and tissue damage. Alright, so first off, type 3 hypersensitivity reactions are mediated by immune complexes. Immune complexes, aka antigen-antibody complexes, are made of 2 parts, the antigen and the antibody. Antibodies, sometimes called immunoglobulins, are produced by plasma cells, which are basically fully matured and differentiated B cells. Initially, these cells make IgM, which can be secreted or bound to the plasma cell surface where it acts as a B cell receptor. When a B cell undergoes cross-linking of 2 surface-bound IgMs, it then takes up the antigen and presents a piece of it to T helper cells via T cell receptor to the MHC class II molecule presenting the piece of the antigen, along with co-stimulatory molecule CD4. The B cell CD40 also binds to the T cell CD40 ligand, and then the T cell releases cytokines, which result in B cell activation and class switching, or isotype switching, where it changes the type of antibodies it makes. In type 3 hypersensitivity reactions, typically B cells switch from making IgM to making IgG antibodies. Now remember that all antibodies are specific, right? Meaning that they recognize specific molecules called antigens, the second part of immune complexes. Antigens can come in all sorts of flavors. Some float around in the blood by themselves and are soluble, but some are bound to cell surfaces. Immune complexes are formed when antibodies bind to soluble antigens. Antibodies can also target antigens on cell surfaces, but these aren't considered immune complexes. And this is the first major distinction between type 2 hypersensitivity reactions, which involve antibodies binding to antigens on cell surfaces, and type 3 hypersensitivity reactions, which involves immune complexes with soluble antigens. A good example of a type 3 hypersensitivity is the autoimmune disease systemic lupus erythematosus, also just called lupus. In lupus, the IgG antibodies are typically specific for DNA and nucleoproteins, both of which are part of our own cells, making them self-reactive. Normally, your body should only react to things that are foreign, or not self. And this is maintained by a process known as tolerance, where only non-self-reactive B and T cells are allowed to mature, whereas self-reactive B and T cells aren't. This process, though, isn't perfect, and sometimes some self-reactive cells can escape, and these can mount an immune response against autoantigens, or self-antigens. With lupus, a DNA autoantigen might get released from a damaged cell, and a circulating self-B cell might find it and bind to it. If a T helper cell that's also specific for the same DNA autoantigen is close by, it'll help activate the B cell and enable it to differentiate into an IgG secreting machine, specific to that DNA autoantigen. Now what? Well, first off, there might be lots of this DNA autoantigen around, since DNA is in most human cells, right? Which allows a lot of IgG DNA autoantigen complexes to form. Now, if this were an infection, there'd be a lot of antibodies surrounding a large single microbe, which marks it for destruction by macrophages and other phagocytes. But in this case, the antibodies are trying to bind to a small, soluble antigen, and there might be lots of antigen relative to the number of antibodies. Small antigen-antibody complexes are less immunogenic, meaning they're less attractive to macrophages, and they don't get removed from the bloodstream as quickly. As a result, the immune complexes float around in the blood longer, and typically make their way into the basement membrane layer of various blood vessels. Once deposited, the immune complexes activate the complement system, a family of 9 small proteins called C1 through C9 that work in an enzymatic cascade to clear infections in various ways. In this case, C1 binds to the antibody-antigen complex, which sets off a chain reaction and activates C2 through C9. When a complement protein becomes activated, it's often cleaved or chopped by an enzyme, which results in little fragments. Fragments C3a, C4a, and C5a are anaphylatoxins and increase vascular permeability, meaning fluid leaks out more easily, which causes edema or fluid buildup. And this is the second major distinction between type 2 hypersensitivity, where complement proteins are activated in relatively small amounts, and type 3 hypersensitivity reactions, where complement proteins are rapidly consumed in large amounts, specifically C3 and C4. which means that the complement levels in the blood can be used to track disease progression over time. The second thing C3a, C4a, and C5a do is act as chemokines, meaning they recruit other cells like neutrophils to the site. Now, once neutrophils join the party, they try and phagocytize the immune complex, but usually they can't. During this process, they degranulate, meaning they dump a bunch of lysosomal enzymes and reactive oxygen species which cause inflammation and tissue necrosis, which ultimately causes vasculitis or inflammation of the blood vessels. With inflammation comes further cellular destruction and more autoantigen release, repeating the cycle again. This most commonly takes place in areas like the kidney where the blood's being filtered, causing glomerulonephritis, as well as the joints, since blood plasma is being filtered to produce synovial fluid, and this causes inflammation of the joints or arthritis. And this brings up a third major distinction between type 2 hypersensitivity, where clinical symptoms correspond to the tissue where antibodies attach to and destroy cells, and type 3 hypersensitivity, where clinical symptoms correspond to the tissue where immune complexes are deposited, not where the immune complexes are made. Now, another example of a type 3 hypersensitivity reaction is serum sickness, which typically happens when a patient receives foreign serum and elicits an antibody response against those foreign antigens. A classic example would be to get bitten by a snake and then get serum with anti-venom antibodies. In response, the body would make some antibodies against the anti-venom antibodies. Now, if that person gets bitten by a snake again sometime later and gets the serum with anti-venom antibodies again, those antibodies that were made the first time around will bind up and make immune complexes with the anti-venom antibodies, which are now being treated like an antigen. These immune complexes then cause vasculitis and tissue necrosis, which would ultimately teach a person not to play with snakes. Post-streptococcal glomerulonephritis, or PSGN, is where the kidney's glomeruli, which is the location where small molecules are first filtered out of the blood and into the urine, become inflamed after an infection by streptococcal bacteria. Most commonly, PSGN starts with an infection by strains of group A beta-hemolytic streptococci bacteria. And this particular group of streptococcus has a specific antigen on its surface that lumps it into a group called group A. This group A streptococci also produces an enzyme called streptolysin, and when the bacteria is grown on a petri dish of blood, the enzyme completely lyses red blood cells that are near the bacterial colony, called beta hemolysis. Beta hemolysis is where they're completely destroyed, as opposed to alpha hemolysis, where the cells aren't actually destroyed, but they're just damaged or bruised. Additionally, these strains are considered nephritogenic strains because they carry the M protein virulence factor, a protein that essentially helps them get around host defenses. An infection by a group A beta hemolytic streptococcus bacteria initiates a type 3 hypersensitivity reaction, where immune complexes are formed composed of antigens and antibodies, often IgG or IgM, that end up being carried in the bloodstream to the glomerulus and become trapped. Specifically, these deposits end up in the glomerular basement membrane, or GBM, and most of the time they're subepithelial, meaning between the epithelial cells, or podocytes, and the basement membrane. It's also possible, though, that the antigens from the bacteria are first trapped in the glomeruli, and then antibodies bind to those antigens in the glomerulus itself. Either way, these complexes initiate an inflammatory reaction in the glomerulus, which involves activation and deposition of C3 complement, inflammatory cytokines, oxidants, and proteases that all damage the podocytes. This damage ends up allowing larger molecules to filter through, like red blood cells and proteins, which then get into the urine and cause hematuria and proteinuria. Those red blood cells in the urine actually often make it darker, or cola-colored. Also, there tends to be less urine produced than normal, called oliguria. These, along with inflammation, are several of the characteristic features making PSGN a nephritic syndrome. Not only that, as less fluids excreted in the urine, more is retained by the body, causing peripheral edema as well as periorbital edema, fluid buildup around the orbit of the eye. Typically, PSGN affects children and follows about 6 weeks after infection of the skin, called impetigo, or about 1 to 2 weeks after infection of the throat, called pharyngitis. Generally, the disease is usually mild and runs its course and spontaneously resolves within a month. Under light microscopy, the glomerulus looks enlarged and hypercellular, and a closer look on electron microscopy shows subepithelial deposits, which appear as humps. On immunofluorescence, the immune deposits cause a starry sky granular appearance along the basement membrane and mesangium, which includes the mesangial cells and other supporting tissue. Blood tests might show antibodies against group A streptococcus, called anti-DNase B, as well as decreased complement levels. Since it's generally a mild illness, treatment's usually supportive. A few children, though, progress to renal failure, and about a quarter of adults with PSGN develop rapidly progressive glomerulonephritis, which can quickly lead to renal failure as well. Alright, so as a quick recap, post-streptococcal glomerulonephritis is a nephritic syndrome involving a group A beta-hemolytic streptococcus infection of the skin or throat that causes immune complex-mediated inflammation of the glomeruli 1 to 6 weeks after infection. Thanks for watching. You can help support us by donating on Patreon, subscribing to our channel, or telling your friends about us on social media.
Let's imagine for a minute that you found yourself in the somewhat unfavourable position of having been bitten by a venomous snake. Now, to treat that, you might get injected with antivenom, which is the serum, or just the liquid part of blood, and it's had the coagulation proteins removed. And it comes from another animal, like a mouse, and that mouse has already encountered that particular venom, and so it's developed antibodies against it. These antibodies can bind to the venom molecules and then render them harmless. Now, normally, that's the end of that. But in serum sickness, your immune system actually mounts an attack against the foreign serum. It's just like attacking a friendly police officer that's just trying to help you out. Serum sickness is a type 3 hypersensitivity reaction, which means that it's mediated by immune complexes, which are combinations of antibodies and soluble antigens. In this case, the antigen is the foreign antibodies in the serum. Now, normally, antibodies, which are sometimes called immunoglobulins, are produced by plasma cells, which are fully mature and differentiated B cells. B cells have multiple IgM antibodies on their surface, and they act like receptors. When an antigen binds two of these receptors, it's called cross-linking. This triggers the B cell to take in the antigen, break it all apart, and present a piece on the surface, on a protein called MHC class II, which stands for Major Histocompatibility Complex class II. Nearby T helper cells can then bind to the MHC class II protein via their T cell receptor, and this happens along with the co-stimulatory molecule CD4. The B cell's CD40 also binds to the T cell's CD40 ligand, and that causes the T cell to release cytokines, which then results in the B cell activation and class switching, or isotope switching. This means that it changes from producing IgM antibodies to producing IgG antibodies instead. After class switching, B cells become plasma cells, and they focus on producing large numbers of this IgG antibody. If this situation was an immune response to a pathogen, like a bacterium, the IgG antibodies would bind to the antigen on the bacterium and mark it for destruction by macrophages and neutrophils. In serum sickness, however, plasma cells start producing IgG antibodies in response to the antibodies that are in the foreign serum, which get mistaken for harmful antigens. This process all starts with the initial exposure to the foreign antibodies, which triggers the B cells to become plasma cells and produce IgG antibodies against the foreign antibodies, and this all usually takes about 4 to 10 days. If there is still foreign antibodies around, the IgG will bind to them and form immune complexes. Since multiple IgGs can bind to the same antigen, we end up with large immune complexes that then get deposited in the basement membrane of blood vessels. All of this can happen in blood vessels throughout the whole body, and that explains the various symptoms that can develop from serum sickness. Once these immune complexes are deposited in the basement membrane, they activate something called the complement system, which is made up of tiny proteins in the blood that attract nearby neutrophils. So, neutrophils come along to the area and then they degranulate, which means that they dump a bunch of lysosomal enzymes and reactive oxygen species, or ROS, on the surface of the blood vessels. And this causes tissue necrosis and inflammation. They also release cytokines, which are tiny signal proteins that attract additional immune cells. That's why there's local inflammation as well as systemic inflammation. Now, let's say this person has a second exposure to the serum. In that situation, the whole reaction would be much, much faster, happening within hours. And it would also be much more potent, because there are already tons and tons of plasma cells from the first exposure, and these are all prepped and ready to produce IgG antibodies against the antigen. The symptoms of serum sickness include fever, rashes, and itching, and these usually start within 1 to 2 weeks after the initial exposure to the serum, or 12 to 36 hours after the second exposure. There might also be lymphadenopathy, or swelling of the lymph nodes, proteinuria, which is an increase in the concentration of protein in the urine, and arthralgia, which is joint pain. The diagnosis is usually made clinically, when there are allergy-like symptoms that start a week or two after the first exposure to the foreign serum. The treatment for serum sickness is generally to use antihistamines and analgesics, which help with the symptoms. Also, and very importantly, avoiding the serum that triggered the reaction in the future. Okay, so to recap the main points, serum sickness is a type 3 hypersensitivity reaction, where foreign blood serum causes an allergy-like response. This happens when small soluble antigens, so the foreign serum, elicit the production of antibodies, and those antigens and antibodies bind together to form immune complexes. These immune complexes then build up on the basement membrane of blood vessels in various parts of the body, and then the complement system is activated, and this causes inflammation within and damage to nearby tissues.
Hi everyone, Sarah here. Thank you for watching that video on serum sickness. I hope you found it informative. The brilliant script was written by Thomas Bush, and the script was edited by Rishi Desai and Ifan Chow. And then I did the illustration and the voiceover, and the whole thing was edited by Sam Gillespie. So big thanks to the team at Osmosis for making it happen. If you liked it, you'll probably be aware that we've got loads more videos on our YouTube channel, which are really helpful for simplifying and making medicine and healthcare subjects a lot easier to learn. But one of the things we pride ourselves in at Osmosis is making this information way more accessible for patients and people who are affected by these conditions. So if you're one of them, or if you're a student and you like what we do, or you don't, let us know, we'd love to hear from you. If you're a student, what you should do is head over to osmosis.org, because there we've got loads more videos that aren't released on the YouTube channel, as well as questions, flashcards, basically everything you need to learn medical subjects. Till next time.
Alright, systemic lupus erythematosus. Okay, we totally got this. Systemic is easy and refers to affecting multiple organs in the body. Erythematosus means reddening of the skin. Alright. Lupus is Latin for wolf, so affects multiple organs, wolf, reddening of the skin. Not exactly. The modern use of lupus usually refers to a variety of diseases that affect the skin, which was possibly originally used since these diseases resemble a wolf bite on the patient's skin. Is that true? Who knows? At any rate, systemic lupus erythematosus, or SLE, sometimes just lupus, is a disease that's systemic and affects a wide variety of organs, but notably often causes red lesions on the skin. Alright, but how does lupus affect all these organs? Well, usually the immune system protects the body's tissues from invaders, but lupus is an autoimmune disease, which means that the immune cells start attacking the tissues they're supposed to protect. With lupus, essentially any tissue or organ can be targeted. And just like a ton of other autoimmune diseases, it's not completely clear why it develops. And like most diseases, it's the result of both genetics and the environment. Alright, so let's go over a specific scenario to show how this usually plays out. Let's say that this guy has susceptibility genes that make him susceptible to getting lupus. And he's exposed to UV radiation in sunlight, which we know is an environmental risk factor for lupus. Well, given enough UV rays, think like sunburn, the cell's DNA can become so badly damaged that the cell undergoes programmed cell death, or apoptosis, and it dies. This produces these tiny apoptotic bodies and exposes the insides of the cell, including parts of the nucleus, like DNA, histones, and other proteins, to the rest of the body. Well, those susceptibility genes specifically have an effect on this person's immune system, such that their immune cells are more likely to think that these are foreign, or antigens. And since they're from the nucleus, we call them nuclear antigens. And those immune cells try to attack them. Not only that though, susceptibility genes also cause this person to have less effective clearance, essentially meaning that they aren't as good at getting rid of these apoptotic bodies, and so they end up having more nuclear antigens floating around. This means that B cells might swing by, see them, and start the production of antibodies against these pieces of nucleus, which are called anti-nuclear antibodies. And these guys are present in almost all cases of lupus. Alright, so those anti-nuclear antibodies bind to the nuclear antigens, forming antigen-antibody complexes. These complexes can get into the blood and then drift away and deposit or stick to the vessel wall in all sorts of different organs and tissues, like the kidneys, the skin, the joints, and the heart. Deposited complexes then initiate a local inflammatory reaction, which causes damage through the activation of the complement system, which, after a huge cascade of enzyme activation, leaves cell membranes with channels that let fluid and molecules go in and out all willy-nilly, causing the cell to burst and die. Usually, though, you'd want this to happen to a foreign cell or an infected cell, not healthy cells. When tissues become damaged as a result of these immune complexes, it's known as a type 3 hypersensitivity reaction. UV radiation isn't the only way to damage cells, though, right? It therefore isn't the only trigger that's thought to be associated with lupus. Other potential triggers that have been associated with lupus include cigarette smoking, viruses, bacteria, use of certain medications like procainamide, hydralazine, and isoniazid, as well as sex hormones, particularly estrogen, which might be partly why lupus is more common in women, especially considering it's about 10 times more common in women than men during reproductive years, but only about 2 or 3 times more common in childhood or past the age of 65. Okay, as a quick recap, the model that's generally thought to be what leads to the symptoms of lupus starts with some environmental trigger, which damages cells and causes apoptosis and the release of nuclear antigens. At this point, the genetic components come in, and the person likely has certain genes that make them not so good at clearing these apoptotic bodies and nuclear antigens. So you end up with a lot of nuclear antigens floating around. In combination, they probably also have genes that cause their immune cells to recognize these nuclear antigens as foreign, which initiates an immune response, creates anti-nuclear antibodies that bind to the antigens and then float around and deposit in various tissues, which causes inflammation. These deposits and inflammation seem to be the cause of most of the symptoms of lupus, which remember is a type 3 hypersensitivity reaction. Many patients, though, also develop antibodies targeting other cells, like red and white blood cells, and molecules like various phospholipids, which can mark them for phagocytosis and destruction, leading to additional symptoms. And this is considered a type 2 hypersensitivity reaction, although it isn't fully understood why some of these antibodies targeting specific cells and molecules develop. So the classic presentation of lupus is fever, joint pain, and a rash in a woman of childbearing age. But the actual diagnosis is difficult because it can affect a variety of people of different genders and ages, and there are also a wide variety of symptoms. There are general symptoms like fever and weight loss, as well as specific symptoms depending on the specific organ system being affected and damaged. In fact, it's so unpredictable that a diagnosis is given only when 4 or more of 11 diagnostic criteria are met. The first few have to do with the skin and often happen to sun-exposed areas. The first is a malar rash, meaning a rash over the cheeks that spares the nasolabial folds, sometimes just called a butterfly rash, and this appears after sun exposure. Second is a discoid rash, which are chronic rashes in sun-exposed areas that are plaque-like or form a sort of patchy redness and can scar. Finally, a general photosensitivity of the skin, essentially a catch-all category for other rashes that happen to sun-exposed areas, typically only lasting a couple days. Another type of tissue that can be damaged is the mucosa, which is the inner membrane of various tissues. So the fourth criteria is ulcers in the mucous membrane of the mouth or the nose. Along with the mucosa, lupus can also affect the serosa, which is like the outer membrane of an organ or tissue. So if it gets inflamed, people get serositis, which could manifest as something like pleuritis, which is inflammation of the lining around the lungs and the chest cavity, or as pericarditis, inflammation of the lining of the heart. Although this isn't strictly a criteria, it's worth noting that lupus can affect any layer of the heart, meaning in addition to inflammation of the pericardium, they might also have inflammation of the endocardium and myocardium, leading to endocarditis and myocarditis, of which the former presents as Lippmann-Sachs endocarditis, where vegetations form, which are essentially these clumps of fibrin, a blood clotting protein, and immune cells, around the mitral valve. Next, if the joints get inflamed, patients might also develop arthritis, specifically needing 2 or more joints to meet the criteria. If the kidneys are affected, patients might develop renal disorders, like abnormal amounts of urine protein, or diffuse proliferative glomerulonephritis, inflammation of the glomeruli. For reasons that aren't completely understood, some autoantibodies that target receptors in the brain have been implicated as well. And this can cause neurological disorders like seizures and psychosis. Sort of along the same lines, patients can have autoantibodies against components of the blood, causing various hematologic disorders. For example, they'll get anemia if blood cells are targeted, thrombocytopenia if platelets are targeted, and leukopenia if white blood cells or immune cells are targeted. And that last one's kind of a mind-bender because it means that your immune system is attacking your immune system. Alright, so the last 2 criteria have to do with specific antibodies being found in the blood. The first one being anti-nuclear antibody, which we already went through. Now, a large proportion of patients with lupus have these, meaning this test is very sensitive. But this test isn't very specific, since these are also seen in other autoimmune diseases. Finally, they can have some other self-directed antibody that is an anti-nuclear antibody, which can be one of 3 types. It could be anti-Smith, which is an antibody against small ribonucleoproteins, or it could be anti-dsDNA, which is against double-stranded DNA, and is often seen more during periods of active disease. And these 2 are relatively specific for lupus. A third type of antibody, though, is anti-phospholipid antibody, which is actually usually against proteins that are bound to the phospholipids, and is less specific for lupus, meaning that it can pop up in other situations. There are 3 types of anti-phospholipid antibodies. Anti-cardiolipin, which can cause a false positive test for syphilis, since anti-cardiolipin antibodies are also sometimes involved in syphilis. The other 2 are lupus anticoagulant, also known as lupus antibody, and anti-beta-2 glycoprotein 1. Sometimes, because of these, patients will develop antiphospholipid syndrome, where the antiphospholipid antibodies cause a hypercoagulable state, meaning they're more prone to developing clots and having complications like deep vein thrombosis, hepatic vein thrombosis, and stroke. These patients often end up needing lifelong anticoagulation therapy. So lupus is characterized by periods of flare-ups and periods of remittance. So treatment is often aimed at preventing flares or limiting how severe they are when they do happen. To help prevent flares, some patients might have to avoid sunlight exposure with hats or long-sleeve clothes. To reduce severity of flares, corticosteroids might be used to help limit the immune response. And finally, if symptoms are really severe, certain immunosuppressive drugs might be used. Thanks for watching. You can help support us by donating on Patreon, or subscribing to our channel, or telling your friends about us on social media. Having a hypersensitivity means that someone's immune system has reacted to something in such a way that it ends up damaging them as opposed to protecting them. There are 4 different types of hypersensitivities, and in the 4th type, or type 4, the reactions are caused by T lymphocytes, or T cells. And so type 4 is also sometimes known as T cell mediated hypersensitivity. T cells are called T cells because they mature in the thymus. And the 2 types of T cells that cause damage to tissues in type 4 hypersensitivity are CD8 positive cells, also known as killer T cells, or cytotoxic T cells, as well as CD4 positive T cells, also known as helper T cells. CD8 positive killer T cells do exactly what their name implies. They kill things. They're these silent assassins of the immune system that go after very specific targets. In contrast, CD4 positive T cells locally release cytokines, which are small proteins that can stimulate or inhibit other cells. So CD4 positive T cells act like little army generals coordinating immune cells around them. But both CD8 positive and CD4 positive cells start off as naive T cells because their T cell receptor, or TCR, hasn't yet bound to their target antigen, which is that specific molecule that it can bind to. Alright, so let's play out a scenario. Let's say someone's skin brushes up against some poison ivy. They'll get this molecule called urushiol all over. That molecule is small enough to quickly make its way through the epidermis to the dermis, which is where it might combine with small proteins, and then it might get picked up by a Langerhans cell, also known as a dendritic cell, which is a type of antigen-presenting immune cell. The dendritic cell then takes it to the nearest lymph node, the draining lymph node, where it presents the antigen on its surface using an MHC class II molecule, which is basically a serving platter for CD4 positive T cells to come check out. If a T helper cell recognizes the antigen, it binds to the MHC class II molecule using its T cell receptor, as well as CD4, which is a co-receptor, and this is why it's called a CD4 positive T cell. At this point, the CD4 positive or helper T cell will also express a CD28 protein, which will bind to the B7 protein on the surface of the dendritic cell. Once it binds to the T cell receptor and the CD28 protein, the dendritic cell releases interleukin-12, a cytokine that tells the naive CD4 positive T cell to mature and differentiate into a type 1 helper T cell, or a Th1 cell, a sort of coming of age moment. At this point, the CD4 positive T cell is no longer considered naive. Instead, it's an effector cell that's able to release the cytokine interleukin-2, which helps both it and other T cells in the area proliferate, as well as interferon gamma, which activates phagocytes like macrophages and creates more Th1 cells. Those activated macrophages release pro-inflammatory cytokines like tumor necrosis factor, interleukin-1, and interleukin-6, which causes leakiness in the endothelial barriers and allows more immune cells into the area, all of which leads to local swelling or edema, redness, and warmth, as well as systemic symptoms like a fever. Activated macrophages will also secrete lysosomal enzymes, complement components, and reactive oxygen species into the exposed area, which damage tissue. In the case of poison ivy, since this is all going on in the skin, it's called dermatitis, inflammation of the skin. This kind of contact dermatitis rash doesn't only happen from poison ivy, though. It can also happen in some people in response to wearing nickel, which is often found in earrings and necklaces. And another classic example is a tuberculin skin test, sometimes called a PPD, which is where a protein from the bacteria Mycobacterium tuberculosis is injected into the skin. If that person's been exposed to TB previously, they'll develop a type 4 reaction, where TB-specific Th1 cells will migrate to the injection site and create an inflammatory response that results in the skin getting thick or hard, called induration. A type 4 hypersensitivity is also sometimes referred to as a delayed type hypersensitivity, since it usually takes about 48 to 72 hours to recruit Th1 cells to the site of exposure. So these skin reactions usually appear over that time window. Apart from skin-related reactions, though, Type 4 hypersensitivity is also involved in several systemic diseases like multiple sclerosis, where Th1 cells damage myelin around nerve fibers, and inflammatory bowel disease, where Th1 cells cause inflammation in the lining of the intestine. In addition to Th1 cells, a naive T helper cell might differentiate into Th17 cells, which is just another subclass of T helper cells. These Th17 cells develop in response to dendritic cells secreting slightly different cytokines, interleukin-6 and transforming growth factor beta. When that happens, the resulting Th17 cells are formed, and they produce interleukin-17, which is particularly important to recruiting neutrophils. Alright, so that was helper T cells, or CD4 positive T cells. But remember that in type 4 hypersensitivity, damage to tissue can also be caused by killer T cells, aka cytotoxic T cells, aka CD8 positive T cells. And these destroy cells directly. CD8 positive T cells target antigens when they're presented on MHC class I molecules, which are present on all nucleated cells in the body, meaning every cell is a potential victim for a CD8 positive T cell. MHC class I molecules present antigens from inside the cell, so this process is important for when cells become infected with viruses or when they're mutated, like with cancer. If this were to happen, then an effector cytotoxic T cell specific to that antigen would use its T cell receptor to bind to the MHC class I molecule, which would cause it to release its payload of perforin and granzymes. Perforin would perforate the target cell by forming pores, and these pores would allow the granzymes to enter the cell. Once inside, the granzymes induce apoptosis, or programmed cell death. Diseases where this cytotoxic mechanism is involved include tissue destruction in type 1 diabetes mellitus, where CD8 positive T cells attack pancreas islet cells, as well as Hashimoto's thyroiditis, where CD8 positive T cells attack thyroid epithelial cells. So, as a quick recap, type 4 hypersensitivity leads to inflammation and tissue damage via T cells, which can be either CD4 positive T helper cells, which help coordinate the attack, or CD8 positive killer or cytotoxic T cells, which directly do the attacking.
With graft versus host disease, graft refers to a section of transplanted or donated tissue like the bone marrow or peripheral blood, and host refers to the tissues of the person receiving the transplant. In this disease, immune cells in the donated tissue attack the recipient's body cells. Normally, the immune system's job is to fight against anything foreign that might cause harm without harming the body's own cells. To make that work, the immune system cells are trained early on to distinguish the body's own cells, called self cells, from foreign cells, called non-self cells. Recognizing whether the cell is foreign or not involves a set of genes called the histocompatibility genes, which make up the major histocompatibility complex, or MHC proteins. These MHC proteins also go by the name human leukocyte antigens, or HLA. The histocompatibility genes actually code for two classes of proteins, MHC class I and MHC class II. MHC class I molecules are found on all nucleated cells throughout the body, while MHC class II molecules are only expressed on antigen-presenting cells like monocytes, macrophages, dendritic cells, and B cells. But because the genes coding for them are so variable in the population, two different individuals will have major differences in the antigens expressed on their cells, even siblings, unless of course they're identical twins. When surgeons do a tissue transplantation, the transplant usually comes from a different person with different genes, and it's called an allograft. If there are immune cells within that allograft, they will see the MHC proteins that coat every cell of the recipient body as foreign. In fact, that's why transplantation donors are really carefully selected to make sure that they share as many of the same HLA antigens with the host as possible. But even between HLA identical individuals, other antigens, called minor histocompatibility antigens, can be recognized as foreign and trigger an immune response between the donor and the recipient. In graft versus host disease, there are three key elements. First, the graft must contain immune cells. This is usually the case in hematopoietic stem cell transplantations, which contain hematopoietic stem cells that can give rise to all types of blood cells, including immune cells. Now, hematopoietic stem cells are derived from bone marrow, which is the spongy tissue inside bones where new blood cells are formed. Alternatively, hematopoietic stem cells can come from the peripheral blood or umbilical cord blood from a newborn baby. Typically, hematopoietic stem cell transplantations are needed by individuals whose own bone marrow doesn't function properly. For example, those suffering from leukemia. The second element is that the host's immune system must be suppressed so that it doesn't destroy the grafted immune cells, giving the grafted immune cells enough time to mount an attack. And the final element is that the host must be immunologically different from the donor. In other words, the host's histocompatibility antigens, mainly the HLA antigens, must appear as foreign to the grafted immune cells. So, shortly after transplantation, the host dendritic cells, which usually hang out in various host tissues like the lining of the skin, might pick up antigens from that tissue and travel to the nearest lymph node, where a lot of the immune cells coming from the donor live. So that's where they meet with the helper T cells and present those antigens upon their MHC class II molecules. If the donor helper T cells recognize these antigens as foreign, they differentiate into type 1 helper T cells, or Th1 cells. Th1 cells then start releasing the cytokines interleukin-2 and interferon gamma, which help both of them and other T cells in the area proliferate. At the same time, these cytokines induce the expression of more MHC class II molecules on the surface of the host cells, which makes it easier for the donor's helper T cells and the host's antigen-presenting cells to interact with each other. Interferon gamma also activates phagocytes like macrophages, which release pro-inflammatory cytokines such as tumor necrosis factor alpha, interleukin-1, and interleukin-6, which recruits more immune cells in the area. Activated macrophages also secrete lysosomal enzymes, which directly damages tissue. In addition to helper T cells, there are also grafted cytotoxic T cells circulating in the area. These cytotoxic T cells recognize antigens presented upon MHC class I molecules, which are on the surface of all nucleated cells in the host body. As before, if these antigens are seen as foreign, the cytotoxic T cells get activated and start secreting perforin and granzymes. Perforin will perforate the target cell by forming pores, and these pores will allow granzymes to enter the cell. Once inside, the granzymes induce apoptosis, or programmed cell death. Apoptosis is also induced by the interaction between a Fas molecule, expressed on the surface of the target cell, and a protein called Fas ligand, expressed on the surface of the cytotoxic T cell. This interaction triggers a cascade of signaling events inside the target cell, eventually causing apoptosis. Overall, the combined actions of helper and cytotoxic T cells results in extensive injury of one or more tissues throughout the body. Now, the symptoms of graft versus host disease can vary wildly depending on the type of tissues affected. And it's not known why some types of tissues, usually the skin, liver, and the digestive tract, are affected more frequently and more severely than others, and why there is a correlation with time after transplant. In the first 3 months following transplantation, there's the acute form of the disease, which typically involves the skin. It causes a painful, itchy rash on the palms of the hands or soles of the feet that can peel or blister and progress to covering the whole body. After the skin, the next most common target is the liver, where the disease is usually asymptomatic, but leads to an elevation in bilirubin, alkaline phosphatase, and aminotransferases like ALT and AST. Acute graft versus host disease can also involve other parts of the digestive system, particularly the distal small intestine and colon, causing diarrhea, intestinal bleeding, and abdominal pain. If graft versus host disease persists for more than 3 months following transplantation, it's considered chronic. Once again, the skin is most commonly affected chronically, and it can cause the skin to thicken. It can also affect the eyes and lacrimal glands, causing a burning sensation and photophobia or difficulty tolerating bright light. Chronically, the proximal digestive tract can also be involved, particularly the mouth and salivary glands, causing dry mouth, sensitivity to acidic or spicy foods, and odynophagia, or pain when swallowing. Less frequently, chronic graft versus host disease can affect the lungs, causing shortness of breath and cough, and the muscles, causing muscle cramps and weakness. Diagnosis of graft versus host disease is primarily based on signs and symptoms, like a skin rash. Lab tests such as liver function tests and imaging studies like liver ultrasound are often useful to assess the damage caused to specific organs. Finally, a tissue biopsy of the affected organ can help confirm diagnosis. Treatment for both acute and chronic graft versus host disease is intravenous glucocorticoids to suppress the T-cell mediated immune response. However, these should be given in moderation in order to avoid raising the risk of infection. Alright, as a quick recap, graft versus host disease occurs when T cells of a graft react against the tissues of the graft recipient, causing a variety of symptoms according to the affected tissue, which most commonly is the skin, the liver, and the gastrointestinal tract. There's an acute form, which happens in the first 3 months, and a chronic form, which happens later than 3 months after the transplantation.